Hi, this is Professor Mulcahy again. We are back in Unit 3, Basic Human Needs Part 2 this time. And now that we have some familiarity with what the basic human needs are and how we prioritize them according to the hierarchy, we'll get into each individual unmet need and how nurses apply the nursing process to help meet them. So we'll start with oxygenation and circulation. As I said, there's a hierarchy within the hierarchy, and this is about as important as it gets. Without breathing in a pulse, really nothing else matters. We are in Wilkinson and Treece, chapters 36 and 37. I have page numbers at the bottom. And we'll start with the functions of the respiratory system, and we'll move on to the circulatory system. And hopefully you'll have a better understanding of how to assess, diagnose, plan, implement, and evaluate your nursing care. We're going to review some of the structure and function of the pulmonary system and all of the systems that are involved in the work of breathing and gas exchange. It's only meant to be a brief overview. If you need more than what I'm giving you, or if something seems foreign or confusing, please return to your anatomy and physiology text, or you can seek out some assistance in your fundamentals texts, pages 935 to 939. Have a nice review of those systems, and it'll give you just about as much as you need to know for this. But anytime that you're confused, go back to your prereqs, because we're kind of assuming that you've had that content. Anyhow, so here's a picture of the pulmonary system, and you can see we start in the nose and the mouth. That is where air is inhaled, it is filtered, it's warmed and humidified, it comes down to the trachea, okay? This is your big airway. It branches off into your bronchi, left and right, and then it goes into these little bronchioles, which look like little twigs or branches, and then finally terminates in the alveoli, little air sacs. They look like tiny little clusters of balloons on the ends of the bronchioles, and that's where gas exchange takes place. While we're talking about lungs, give me a minute, I'm going to get something up here for you. Just bear with me. Okay, and I hope this GIF kind of comes through on the video file that you get, because it's a nice little illustration. Ventilation relies on a couple things, okay? You need lungs that can, we call it elastic recoil. Anybody who's ever played with a rubber band and kind of stretched it out and snapped it back understands elastic recoil. It means that when you stretch it out, it comes back to its original shape. So it can expand with air and then sort of exhale that air. It comes back and forth without being brittle. We also need lung compliance. And these are lungs that will respond to inhalation. So they expand easily and then they recoil. They go back to their original shape. So you need that. You're also going to need, see that diaphragm is going to have to move up and down. And that relies on healthy nervous function, which we're going to talk about next. So those are some things about the lungs. You also need alveoli that have a normal surface and a normal thickness in order to exchange gases, oxygen and carbon dioxide. Okay, so let me X this out, and then we'll look at the alveoli next. Sorry, let me X out this because you don't need it. Okay, so here is a picture of the alveolar capillary junction. And you can see it's like this little balloon, like I said. And we know that oxygen goes out. It's a passive diffusion, so we have more oxygen in the alveoli than we do in the bloodstream if the blood has deoxygenated blood. So the oxygen goes in and out to the tissues, and then the carbon dioxide, because there's more of it in the blood than there is in the alveoli, goes in through passive transfer and it can be exhaled. And so that's where gas exchange takes place, and that's going to become important to you at some point during this discussion. Okay, what else do we want to look at? Let's look at this complicated little picture. You don't have to memorize it, and don't get too excited about it. I know it looks very elaborate. But what I want to point out to you is that it's not enough just to have a nose, a mouth, a trachea, and healthy lungs. You also have to have a brain, and you have to that will respond to signals, and you have to have muscles, which are up in the top right corner, that can assist breathing. So the brain has two main centers that control breathing. It has the pons and the medulla oblongata. You don't have to memorize that. This is a review. But just know that when you have brain damage, it can affect the ventilation because the brain is what tells the muscles to go back and forth. Remember, this is an involuntary reflex. You don't have to think about breathing to breathe. That's why when kids hold their breath and pass out, eventually they go back to breathing because the brain takes over. So you need to have a functioning brain. And let's see. I'm just going to show you these things. Chemoreceptors. Kind of remember that chemo means like chemical. And it means that the brain's going to respond to low levels of oxygen, that's called a hypoxic drive, and high levels of carbon dioxide. When the blood gets hypoxic, the brain says, okay, gotta breathe, and it makes those muscles sort of expand, and then it makes the diaphragm drop down so that the air can come in and be inhaled. It keeps the body breathing. So the brain is receptive to these chemical signals when oxygen is low. We also have stretch receptors in the lungs. And irritant receptors. And when the body needs to take a breath, the brain will send signals out to the lungs, and when the lungs get stretched to their, to the capacity that's needed, then there's an exhalation. It's really, we don't have to get too fancy with it. Just remember, you need a brain, you need nerves, and you need normal signals going to the brain. That's going to become important when we talk about chronic obstructive pulmonary disease, or COPD, which is a disease caused by years of smoking. What ends up happening is that those irritant receptors and those stretch receptors don't work anymore. So the only thing providing the brain with the message to breathe is a slight hypoxia. So their pulse ox is going to be a little bit lower, otherwise they won't breathe at all. Just tuck it away in the back of your mind. This was only meant to be an A&P review, and don't get too far ahead of yourself. But it will make sense when we start to pick it up again later. Okay? Now I'm going to talk about the muscles. And this picture looks a little complicated. Let me kind of straighten it out there, but it's not really. Basically, I just want you to understand that you need a diaphragm that moves down so that you can take a breath in, and moves back up so you can exhale that air. You need the thoracic muscles that will open the rib cage, kind of move the rib cage back and forth. You have intercostal muscles that also facilitate the work of breathing. Now, the sternocleidomastoid muscle is that muscle in the side of your neck. You'll see it right here. And that's an accessory muscle. And a lot of times you will see that when people have labored breathing, when they need a little extra help to breathe, they'll start straining that sternocleidomastoid muscle. But all these muscles are important in the work of breathing. So that is your brief overview of the anatomy and physiology. So now I'd like to talk a little bit about ventilation. Remember that I've split this up into ventilation, gas exchange, and then we talk about perfusion as part of circulation. Okay, so ventilation is the act of moving air in and out of the lungs, in and out of the airways. Okay, and so we have our breathing patterns. And I don't know how many of you remember doing your medical terminology over the summer, but anything that has to do with a breathing pattern ends in that suffix, the PNEA. Okay, so apnea is the absence of breathing. Let's kind of put that in. Anything that's A means none, so no breathing is apnea. Eupnea is good breathing. Anything with that prefix, the EU, whether it's euglycemia or eupnea, means it's all good. So that's eupnea. We have, tachypnea. And tachy means too fast, so that is rapid breathing. And that is defined by age-related norms, and we'll talk about that in a minute. We have bradypnea. Anything that is brady, anything is low. So we have, at that point, slow breathing. Now, any of these patterns can lead to problems with ventilation. We have hypoventilation, and this can be shallow breaths or it can be too few of them. But hypoventilation means that you are not ventilating enough. You are not breathing enough. It's pretty simple. Hyperventilation means you are breathing too much, and that happens when people are under stress. And we'll talk about what happens there, because creates a lot of symptoms that are uncomfortable for the person, and they're pretty easily corrected. Sometimes the body gets into really, really abnormal breathing patterns. So let's see if we can shrink this now that you have it. Of course, anytime you need to stop and take a note, that's the beauty of the videos, you can. So here are some pictures of what's called capnography, and what this is that a machine sort of captures breathing, and it looks like a seesaw pattern. As you breathe in, that there's a spike, and as you breathe out, it's lower. Okay, so we're going to start with eupnea, that normal breathing pattern. In an adult, that looks like 12 to 20 breaths per minute. Children breathe faster than that. Newborns will breathe 30 to 60. Older children could be 20 to 30. It depends on the age, really. But as children get older and their lungs get bigger, their breathing slows down. So in an adult, this would be a normal breathing pattern. Bradypnea, as we said, is breathing that is too slow. So say somebody's medicated or they have a heroin overdose, you would expect their respirations to be slower, and you do something to reverse that. Tachypnea is a lot of times a compensatory response. This is breathing that is too fast. So people need more air, they breathe faster. Hyperventilation is really tachypnic, and that's, hyperpnea. Sometimes people in a panic state or anxiety state will have hyperventilation, and we'll also see it with Kussmaul's, which I'll show you in a sec. And we'll talk about what those might look like and how they might present. Cheyne-Stokes breathing, a lot of times you see this in hospice when people are at the end of life. They get into a breathing pattern, and it is something that happens in their brainstem. It's not something that's happening in their lungs, really. But the nervous system sort of adopts this pattern where they have periods of apnea, and there's the apnea, and then little shallow breaths, then sighing breaths, and then they go back to the little shallow breaths, and then another period of apnea, and they repeat that cycle. It's if I can find a video of it, I'll kind of show it to you in class. But it is sort of an agonal pattern. When people are Cheyne-Stokes breathing, you start getting a little bit nervous, unless you're expecting end of life. Kussmaul's respirations are this really tachypnic pattern, but it's not tachypnea that's shallow like over here. It's very many deep breaths. Okay, so really hyperventilating, rapid deep breaths. And what this is usually a sign of, you'll learn more about it in acid-base balance, but here's your sneak preview, is that the body is trying to blow off the acid that's caused, that's in the body, by getting rid of more carbon dioxide. Carbon dioxide turns to acid in the body. So if there's a problem in the body that's creating too much acid that's not coming from the lungs, the body will try and compensate. So you'll see Kussmaul's when a patient is in an acidotic state. Take a note and tuck it away, because that does become important in a couple of different places in your academic career. You'll see Kussmaul's when Mrs. Roberts talks to you later in the semester about acid-base balance, and when with that unit, with the fluid electrolyte and acid-base balance unit. And you'll also revisit that whenever you get to diabetic acidosis or any acidotic state. So Kussmaul's breathing would be the pattern that you would notice. And again, it is that rapid, deep breathing. Not rapid and shallow, rapid and deep. It's getting as much oxygen in and blowing as much carbon dioxide off as possible. And then you have Biot's respirations. And next we have Biot's respirations. And Biot's respirations are sort of this chaotic, irregular pattern followed by periods of apnea. And it's usually signaled by some brain damage. Again, the medulla oblongata and the pons are not functioning appropriately, and so they're not sending appropriate signals to the body to breathe. And we have ataxic, which is similar, again, caused by brain damage, but it's like a completely chaotic and unpredictable breathing pattern. And so those are some of your breathing patterns. And those particular items are not really found in Chapter 36. Instead, they are found, still in your text, Wilkinson, Treese, Barnett, and Smith. Try to give credit where credit is due. There's a nice table on page 444. Ataxic respirations aren't part of it, but that's okay. You get the point of what they are. They're just uncoordinated breathing patterns. Okay, so let's talk about some of the factors that have an influence on ventilation. And the first one your book talks about is age. Now, there are special considerations in each age group or developmental category. We'll start with the preterm newborn. Their lungs just aren't ready to work. At about 24 weeks gestation, you start seeing the manufacture of surfactant, but it's really not enough until that kid's about 34 weeks. And so they'll usually administer surfactant. Without surfactant, the lungs are very stiff. And so trying to ventilate a kid who's got preterm lungs without that surfactant is really, really tough. You really have to work the bag to get that breath in. And so we see how important surfactant is. Surfactant also reduces the surface tension in the alveoli and promotes gas exchange. So age is, plays a role at all times. We, go on through term newborns, toddlers. Obviously, you have things like choking hazards, suffocation hazards. Remember that age influences ventilation rate. Because the lungs are smaller, they have to work faster to do the same amount of work, to get the same amount of air in and out. And then when we get to the older adult, sometimes we lose our lung capacity or the elasticity in our lungs, just like everything gets a little less elastic. And so age does have an impact on ventilation and developmental level, I should say. Okay, so I guess the next thing that we should talk about is the environment. Environmental irritants, like allergens, let me kind of put these things away so we're not, I'll put smoking in there, might as well. Okay, environmental irritants are going to inflame the airways, and that does influence ventilation. Allergies, mild allergies in themselves are not going to significantly impact ventilation, but when it gets to the point where you have anaphylaxis and those airways close, you can't get any air in. Obviously, so person who has an allergy to penicillin and you administer that medication, person who has an allergy to shellfish and they go into anaphylaxis, their airways will close. Allergies, environmental allergies like hay fever and seasonal allergies can also trigger asthma in certain individuals, and asthma does narrow the airways, and so those are some things that impact ventilation. Altitude, the air is thinner, and so people tend to compensate for that with a slightly faster rate of breathing. Temperature and humidity will increase. Extremes of temperature, cold and heat, will inflame the airways and can cause what's called bronchospasm, which is when the airways sort of get a Charlie horse and they tighten up and now you can't get the air in. Excessive humidity also increases the work of breathing, particularly in your elderly and in your very young children. That's why you have those heat warnings in the summertime or the cold warnings. Stress, both physical and emotional stress will change the respiratory rate when people hyperventilate. We'll see how that looks. But they have an ineffective breathing pattern. They breathe rapidly. It impacts on their gas exchange because they have lower carbon dioxide. That causes some symptoms. We'll talk about that with gas exchange and assessment. Air quality, obviously, same thing with allergies. When you have pollutants, they inflame the airways. And smoking, obviously, smoking destroys the airways slowly over a period of time. And so it will negatively impact ventilation. The thing that you want to talk about with smoking, we'll talk more about that with interventions, nursing interventions, is that when people quit, they can start to heal right away. Their ventilation improves within hours of their last cigarette. So those are some environmental factors. Let's talk about nutrition next. Why not? Okay, so a couple things about nutrition. Nutrition helps support the immune system, and so it can help people avoid the pneumonias and the upper respiratory infections and a lot of the infectious processes. Good nutrition also promotes tissue repair, so if you do have a disease of the respiratory system, it helps repair that. Poor nutrition, particularly nutrition that leads to obesity, definitely impacts ventilation. Obese people have abdominal fat often that presses their diaphragm upward, and if you remember my A&P review, that diaphragm drops down to let you get a good breath in, and so when you have a diaphragm that doesn't want to go anywhere because there's a fat pad in the way, you'll have more difficulty getting a deep breath. Also, people with obesity tend to have, because they have smaller lung capacity, they don't tolerate activity well, and that means that they don't exercise, so they never increase their tidal volume unless they make an effort to do that. And they suffer at higher incidence of what's called obstructive sleep apnea. You've probably heard of sleep apnea or seen people on CPAP for sleep apnea. And sleep apnea happens when some people lay down to go to sleep. Their tongue occludes their airway, and it's more common in the obese population because the airways are smaller. Okay, so that is some information about how nutrition impacts that. Exercise. When you do aerobic or cardiovascular exercise, you increase your lung capacity. The more mild stress you put on that system, the more conditioning you get. And so exercise can be an intervention that we promote for better ventilation. Poor ventilation impacts on exercise because people who have poor oxygenation can't tolerate a lot of exercise. So that's something to keep in mind. You always want to make sure that you're only going to that person's capacity and you're not exhausting them. And where to next? Let's go to medical conditions. There's a couple things. Anything, obviously, that impacts the airways, like asthma, like lung cancer, like chronic obstructive pulmonary disease. Any pulmonary condition is obviously going to impact on ventilation. Now, also, with ventilation, any brain disorders that impact the brainstem or the medulla oblongata or the pons, any brain damage in that area is going to negatively impact ventilation. Spinal cord injuries at the level of the cervical spine, or the thoracic spine, the nerves that innervate all the muscles of breathing, all the structures of breathing. If you have that paralysis, or if you have damaged muscles, those are some things that can influence ventilation. And there are many, many, many conditions that come under the pulmonary umbrella, which some of them you'll talk about with this unit, and some of them you'll get into more in senior year when you do the pulmonary system and when you do ICU. Medications and anesthesia. Now, when we talked about the brain responding to signals and sending out signals to the muscles to sort of make that chest cavity expand and retract. Any medication that depresses the central nervous system, such as your anti-anxiety medications or your sleep medications or your narcotic pain medications in particular, especially anesthesia. And so your post-op patients and your patients who are taking these medications are definitely going to need to be targeted for some kind of intervention to help maintain a patent airway and to promote effective ventilation and effective breathing patterns. Okay, so pain will impact people who have incisional pain. Your post-op patients are really, really at a critical point, and you can do a lot of good by helping them recover from the effects of surgery. In particular, pain affects breathing because people don't want to take deep breaths if it impacts their incision, if it makes their incision hurt more. And so you're going to teach them things like how to splint your incision, and you're going to manage their pain appropriately. Not over-narcotize them maybe, but make sure that they can tolerate the level of pain that they have, because that's really going to impact their breathing pattern. If they don't breathe effectively, particularly your post-ops, their secretions will sit in the bottom of their lungs, and they won't. If they don't cough and deep breathe, they won't mobilize secretions, and then that becomes sort of like an atmosphere for infection. It's like a little petri dish. So those are some of the factors that influence ventilation. Okay, so we've already kind of discussed how gas exchange works at the level of the alveolar capillary membrane. Gas exchange also occurs between the oxygenated blood and the cells that have to exchange oxygen and carbon dioxide. So those are the two gases that we normally talk about with gas exchange. Your book has a nice table on page 943. Let's put that page number up there in case you want to look at it. Okay, so it's box number 36-2, and it has these terms. We're going to talk about hypoxemia. These are alterations in gas exchange. Hypoxemia means that the blood doesn't have enough oxygen. That emia tells you that we're talking about blood, like anemia means that there's not enough red blood cells. So hypoxemia means low oxygen levels in the blood. Hypoxia is low oxygen level in the tissue. So the tissues are starving. They're related terms and they're kind of similar, but they're not exactly the same. So when we say that somebody's hypoxemic, we know that their blood gases are low in partial oxygen, which we'll talk about a little bit later. Hypoxia means that the tissues are starved for oxygen, and that'll give you a different set of tissues. Now we can have hypercarbia. When you get into patterns that are hypoventilatory, people aren't breathing enough, they're not taking in enough oxygen, they're not blowing off enough CO2, and the carbon dioxide builds up in the body. And so you have an excess of CO2 in the blood. Okay? And the bad news about that is it can create a condition called respiratory acidosis, because carbon dioxide becomes an acid in the body called carbonic acid. Okay, you've heard that now for the second time. You're going to hear it another time, and then you're going to, delve in deeper when you get to Unit 7, which isn't for maybe about a month and a half. But that's hypercarbia. It's an excess of CO2 in the blood. And then we have hypocarbia, which means there's not enough. So inadequate CO2 in the blood. And this happens with your hyperventilation patterns. Now that can happen as a result of stress or pain. It can happen as a compensatory mechanism. We talked about that a little bit. But when you have hypocarbia, the signs and symptoms that you're going to have are going to be like tingling around the mouth, tingling around the extremities. When it gets severe, you're going to have muscle twitching or spasm. Numbness and tingling in the face and lips are the first signs. So if you have a person who's hyperventilating because maybe they're in labor and they're in pain, you just get them to slow down their breathing. Worst comes to worst, you can have them breathe into a paper bag, and that's going to help them rebreathe some of the carbon dioxide. If they blow up that paper bag, you know that they're blowing off some CO2, and then they just rebreathe it, and that'll usually correct the pattern. If it's something more along the lines of a compensated acidosis, you're going to have a whole different set of interventions you don't have to worry about now. But those are the terms we talk about that tell us that we have impaired gas exchange. Okay, so some factors that impact gas exchange. You need to have a normal alveolar membrane. If you have a normal thickness in your alveolar membrane, the gases are able to diffuse relatively easily. And you need to have enough available surface area of the lung tissues. So conditions that can impact the thickness of the alveolar membrane, if you have emphysema, that membrane gets thicker and stiffer, and it can be more difficult for those gases to diffuse across that membrane. Surface area of the lung tissues, obviously, if your lungs collapse or if your airway is narrow, as in when you have bronchospasm with asthma, or when you have a collapsed lung, that's going to impact your gas exchange. Now we can also have problems with gases being unable to diffuse if they have to sort of travel a little bit further through fluid. So if you have fluid in the lungs or secretions in the airways, you not only now have an obstructive airway or ineffective airway clearance, but you can have impaired gas exchange as a result. We already talked about surfactant. Surfactant is this detergent-like chemical that is produced in the alveoli. So if you have a deficiency of surfactant, there are a couple of different conditions that can cause it. You don't need to know them now. Even oxygen toxicity can cause a deficiency of surfactant. That's going to make it much more difficult to have effective gas exchange. And obviously if you have obstruction of the pulmonary circulation, there are all those vessels that supply the lungs with air. If you have what's called a pulmonary embolus, that's going to make the blood that is supposed to give off the CO2 and absorb the oxygen, blood's not going to be able to circulate to the alveoli, so you're not going to have gas exchange there. Now there's also a condition called atelectasis. And atelectasis is a collapse of the airways. It starts in the alveoli, they get deflated down to like those little balloons get shriveled up, there's no volume, no air volume in them. And that can occur from hypoventilation over a period of time. You have your patients who are on bed rest or they're post-ops and they don't take effective deep breaths and they don't cough, and so those airways kind of collapse. And that can lead to collapse of the major airways. So those are some conditions that impair gas exchange. Okay, and the last thing we're going to talk about, it's in red, is that you also have gas exchange at the level of the tissues. It's only one part to get the oxygen into the blood. It also has to be then delivered to the cells, and the cells have to exchange their metabolic waste, which is carbon dioxide. So you can have impaired gas exchange at the level of the tissues, the peripheral tissues as well, especially in altered metabolic states where the body can't keep up with the tissue's demand for oxygen, or when we have inadequate circulation to those tissues. So that is impaired gas exchange. Okay, so now that we're a little bit familiar with the oxygenation process in the body, we're going to talk about using the nursing process to address problems with oxygenation. And this is sort of where you need to focus your attention, because your unit exams, your NCLEX, and really the basis of your clinical reasoning is going to be centered around the nursing process, particularly assessment, planning interventions, and evaluation. So let's get started on assessment. And for more information on this, you can go into your Jarvis text. We are going to cover all of this information in more detail in Nursing 137. But just to give you an overall background on how we use the nursing process, we're going to start with assessment. And I've given you the acronym of HIPAA, not to be confused with the privacy HIPAA, which has 2 A's. History, inspection, percussion, palpation, auscultation. And that's a pretty good mnemonic to use for any assessment other than the abdominal. And again, we'll talk about that later. A thorough history is going to reveal risk factors, such as demographic, extremes of age. Obviously, people at either end, the very young or the very old, are at risk for pulmonary disorders. Past medical history. Do they have a history of asthma? Have they had pneumonia in the past? Do they have any cardiac history, which might have implications for fluid in the lungs? Do they have history of maybe blood clotting disorders, where they might get a pulmonary embolism? Any other history that you want to get, respiratory or cardiac, is going to be really helpful in identifying problems. Environmental exposures. We're going to look particularly at things like asbestos, allergens, tobacco, and other smoking history. Very, very important. We want to know how many packs a day that person smokes and for how long, and that'll give us a formula called pack years. For example, if I've smoked for 15 years and I smoke 2 packs a day, I have a 30-pack year history, and that correlates with a risk for COPD, lung cancer, and other disorders. Chemicals, irritants, you want to know where that person works, and if their living space is free. I mean, some people live in old buildings and there's mold or there's other environmental toxins, and we want to know about lifestyle. If the person exercises or doesn't exercise, do they control their weight? And we want to know, basically, like I said, the tobacco and or other smoking history, and I do add that because some drugs are inhaled or smoked. For example, obviously people who smoke marijuana or crack cocaine or crystal meth are compromising their airways. People who inhale drugs, they snort heroin or cocaine, might inflame the nasal passages and cause problems, ulcerations within the nose. So we want to get a thorough social history. So those are some risk factors that we're going to assess for, and then we're going to assess for the person's symptoms. And symptoms really indicate, subjective data. Remember, signs are objective, and the difference between subjective and objective is that subjective is what the patient reports to us, whereas objective is what we find ourselves when we look or listen or feel. So some symptoms that we're interested in are shortness of breath, coughing, and activity intolerance, to name a few. We would also want to know about chest pain, but we'll kind of cover that a little bit more when we talk about circulation. So shortness of breath, we want to know, when did it start? How often does it happen? What triggers it, makes it worse, makes it better? And one example of this might be somebody who says, I can't walk more than a block without getting short of breath. Somebody else might say, I can't go up 2 flights of stairs without getting short of breath. Somebody else might say, I get short of breath just walking from my wheelchair to the bathroom. Another thing you might want to note is what time of day. People who have more shortness of breath at night have what's called paroxysmal nocturnal dyspnea, so I will write that down. And
And this you see very frequently with congestive heart failure. And what happens when the person lays down flat, the fluid sort of backs up into their lungs and they can't breathe. They sit straight up. They have nightmares. It's pretty intense. They wake up drenched and then they have to sit straight up, and it takes them a long time. They can actually get a lot of anxiety related to that, obviously. So the next symptom that a person might report, they might say, I've been coughing. So we want to know, when did this start? Did it start when you had a cold and you had a fever? Did it start at the beginning of allergy season and it aggravated your asthma? Did it start 5 years ago because you're a smoker? Did it start 2 weeks ago? So you want to know how long this person's had that. You want to know, how often does it happen? Is it pretty much constant nagging all day long? Does it keep them awake at night? Is it worse in the morning? Now, smokers' cough usually is worse in the morning, whereas somebody who's got a pneumonia will frequently find it worse at night when they lay down to go to sleep. So you want to know what time of day. Triggers, things that aggravate it, things that make it better. People will notice that heat, extremes of temperature, heat and cold can make it worse. They might notice activity makes it worse. Also with coughing, any secretion in the body, just about, we're going to assess something called, I'm going to call it COCA. Color, odor, consistency, and amount. It's not the last time you'll hear me say that, because whenever you document on a finding, you want to know what color was it. Now, sputum that is clear or white is one thing. That's usually benign. Sputum that is yellowish or green usually means infection. Sputum that is rust colored means that there is old blood. You can have we call that chocolate hemoptysis, where it was like really brown. And again, that's old blood, and you see that with lung cancer and you see it with TB. You can have frank red bleeding, which is usually the smaller blood vessels in the throat that are bursting with the effort of coughing. You want to know the consistency. Is it thick and what we call tenacious? I'll put that up. That's a word you're going to see. And that means that it doesn't want to come up, that it is just this thick, gross, yucky stuff that wants to stay in the airways. It kind of clings. Or is it, thin and watery? The thinner the better, really, because you want to be able to mobilize those secretions. And the amount is obviously important. We want to know, is this a lot? Is it a little? Are they coughing up tons and tons of stuff? Or are they unable to cough up very much at all? So, let me get that back there. Sorry. Okay. So activity intolerance is another one. And that's when we talked about how much of their activities of daily living are impacted by their lack of oxygenation. It goes back to sort of that shortness of breath. But it also includes fatigue. The patient might feel just wiped out. They do one load of laundry and they have to lay down because they don't have the energy. My mom died of lung cancer, and towards the end, she would get through half of a soft-boiled egg and say, I can't do it anymore. It's too much energy to eat. And that's, so we can look at their activity intolerance and see how this problem is impacting them. So when we get to inspection, you're going to start inspecting your patient before you even walk into the room. You'll listen a little bit, but mostly you're going to look. And you're going to look for the work of breathing. So let's talk about what labored breathing looks like. Labored breathing looks like nasal flaring. The patient involuntarily, the brain's getting these signals that are like, wait, hold on, I'm not getting enough air. And it's going to have the person sort of involuntarily open up their nasal passages as wide as they'll go to let in as much air as possible. And you'll also see retractions sometimes, or use of the accessory muscles. And what this looks like, the chest wall almost looks like it caves in. And there's this pulling of the intercostal, between the ribs, intercostal muscles. I'm sorry, I'm not getting the words out fast enough. Or you can see it at the suprasternal notch, sometimes above the clavicles if you're looking at them in the upper airways. And what that usually means is that the person is really working to breathe and there's maybe a little obstruction. You'll also see the accessory muscles, the sternocleidomastoid, which is that muscle on the side of the neck, will start to get stressed. And the more this person is using their accessory muscles and the more retractions you see, the more seriously they are working to breathe. Grunting is another thing, and whenever I see grunting, I think of newborns because that's, really my field. And grunting is almost like nature's CPAP, and it doesn't sound like what you think it would sound like that, when you pick up something heavy. It's more of a, and it is like the body's attempt to force the air down. It's almost like positive pressure that the body is exerting, holding that diaphragm down, really forcing it down to let the air in. So that's what grunting is. And then you'll also see people assume the tripod position. And let me see if I can get a picture of that up here for you. I'm pretty sure I have a good one. There it is. Here's that guy. You see he's very thin also. Again, we go back to that whole having difficulty eating and activities of daily living. They start to sort of waste away. But you see that he's leaning forward. He's up almost as high as he can go, and his hands are on his knees, and he's trying to open up that chest cavity as much as possible to let in the biggest possible breath. Okay, and the next thing on our list is tachypnea. Now, before you even get your watch out to count your respirations, or if you're relying on your assistive personnel, you're going to get pretty familiar, the more respirations you count, with what 12 to 20 looks like. So when it's outside of that range, something in your head should sort of say, oh, something doesn't look right. They look tachypnic. I see him working a little bit more, and that's the body's compensatory mechanism. Gasping and conversational dyspnea, those are not good signs. And a lot of times you'll walk into the room, and like I said, you're not even formally assessing this person, but you're already assessing without even thinking about it. When you say, good morning, how is your breakfast? And the person answers you in these little snippets where they can't finish a sentence, like, well, it's not bad, but I'm not very hungry. They get that breathy quality to their voice, and they have to pause frequently and take in a breath. Gasping is another one. If they breathe in like a fish out of water, that's also a sign of respiratory distress. And so labor breathing is something that you're looking for right away. Also notice if those respirations are symmetrical. If one side of the chest is working and the other one's not, you got a problem. And particularly with people who have chest tubes, definitely make that assessment part of your just everyday, not even thinking about it kind of thing. Another way that we can assess person's oxygenation status is we look for signs and symptoms of hypoxia. And what hypoxia looks like, the first sign, the brain is the most sensitive tissue. If it's not getting oxygen, it's going to start sending out big red flags and alarm bells. And you're going to see this person go from being relatively quiet and coherent to being very anxious and agitated and restless, thrashing around the bed. They might say, nurse, something is wrong. I know something is wrong. Something horrible is happening. They get that sense of impending doom. And that is your first sign of hypoxia. And I'm going to actually put a little star next to that because I think that's kind of important, that if you walk into the room and the patient is thrashing around the bed, don't think that you're going to get your bed bath done right that second. You're going to assess their respiratory status first, please. And come get me if you have any other issues. Anxiety can be caused by other things, but the first thing that you should always assess when you see somebody who is normally not anxious and upset is their oxygenation status. Patients who are on ventilators who start to thrash sometimes need to be suctioned because their airway's not patent. So look for that. You're also going to look at that patient's color. Again, this is going to become almost subconscious. You don't really think about it. You walk in the room, you go, ooh, he doesn't look good. It's his color. Well, cyanosis is kind of interesting in that it goes from that peripheral to the central. And that's because the body's a smart machine, and the body knows how to prioritize. It knows that the brain and the heart and the vital organs are more important than anything else. And it's going to shunt oxygenated blood away from your fingertips and your toenails to get it to those vital organs, particularly the brain, the heart, and the adrenals. So you'll see it in circumoral, which is around the mouth. I'll get a picture of that for you. You're going to see more of this in 137. I don't want to beat it to death, but there you go. Okay. And there's a baby with circumoral cyanosis. There we go. Or you can see it on the fingertips. I'll get that up for you. And these are earlier signs of hypoxia. See? Okay. As hypoxia progresses, by the time you get to about 85% arterial oxygenation saturation, now you're looking at central cyanosis. So central cyanosis, so I'm going to make a little note so that you remember that, is a bad sign. It is a terrible sign. So if you see somebody with central cyanosis, you're looking at their chest and their abdomen, and they have cyanosis there. You are looking at a patient who is very, very hypoxic, and you're probably seeing other signs and symptoms as well. Now, we're on the subject of cyanosis. It can be difficult to determine if a patient who is dark-skinned, whether they are from East India or they're African American or some Asians, it can be sometimes tricky to tell if they're cyanotic or not. And in fact, in 137, your Jarvis text is going to tell you that some African Americans have a variation of normal where the lips are sort of dark and dusky and maybe a little bluish. This is a little bit different. And so when you inspect in the mouth of a patient who is naturally dark-skinned, first of all, you should get to know your patients when they're not in distress. That's always the best way. And then you know if there's a change. But the other thing is that you're going to kind of look at their overall breathing patterns and correlate it. And you can look at their gums and their hard palate, and that's going to give you a better feel. If you're not sure, my thing is when in doubt, if you think the person needs a pulse ox, put a pulse ox on them. It never hurts. Now, when you get chronic hypoxia, you'll see things like clubbing and barrel-chestedness. I'll put those pictures up for you really, really quick. We're all... There we go. Clubbing. Okay, so you see clubbing. And what clubbing is, it's an increase in the angle of that last phalange of your fingertips. And the nails become spoon-shaped. Everything gets sort of weird and puffy, and that's really from chronic hypoxia. So that's one sign. And another sign that you can have is a barrel chest, and that's common with patients who have emphysema because their airways are always a little bit inflated. So let me get a picture of that up there. There we go. And you can see the anteroposterior diameter of the chest changes a lot. And that's one of the changes. It's sort of a compensatory mechanism in part, but it's because the alveoli, all the airways, are always a little bit inflated and sometimes hyperinflated, so you get these structural changes in the chest. Okay, so that's some of the stuff that we are assessing for. Cough. Now we want to know, is it productive, is it not productive? When you are observing someone cough, again, we looked at subjective data. Now we want to look, do they look like it's wearing them out? Do they look like they're bringing anything up? Does it look like it's a strong enough effort to bring something up? We might have to help them out a little bit by helping them mobilize secretions. And you want to note the color, consistency, amount of any sputum. Okay, so that is inspection. Percussion and palpation are other ways that we can tell what's going on with the respiratory system, and for a more thorough discussion of that, I'm going to defer until Nursing 137. And auscultation, obviously. We listen for normal breath sounds like vesicular or bronchial or bronchovesicular breath sounds. I can play them for you in class, but I know you're going to get them again in 137, so I'm not going to go too nuts. And then we have our adventitious breath sounds. We have rails, which also are called crackles. Let me get that up here for you. In fact, I think the more common terminology that you're going to see is crackles. And they are indicative of fluid in the lungs. So you'll hear them and they sound like a crunching or crackling, as the name would imply. We have rhonchi. Rhonchi are from secretions. Or they're also called low-pitched wheezes. Usually you can clear them with coughing if you have a good effective cough. So they sort of sound like a gurgling. And again, when we get to 137, I'll play those for you. And then we have wheezing, which can sound like a whistle. Ooh, sorry, my typing is terrible. It can sound like a whistling, or it can sound like a snoring or squeaking. And that's indicative of narrowing of the airways, okay? So wheezing is something that we want to act on to open up those airways. Some smokers have chronic wheezing, but asthmatics, if they have an exacerbation of their asthma, are going to get more significant wheezing, and that's when we want to act. And now I'm going to talk about stridor. And stridor is a very harsh, crowing... Oh, no, that's not how it's spelled. It's spelled with an O, sorry. Stridor is a harsh, crowing, or barking almost sound. And that means that the large airways are narrowing. When we hear stridor, and we know that there's a big enough obstruction that we're hearing it out loud without a stethoscope, this is one of those things that if you're hearing it, it needs intervention. Particularly you have somebody who was intubated and now they've been extubated. Maybe they have a little swelling or edema. If that airway closes all the way, you're going to have to trach the person. So when you hear stridor, act immediately. So that is basically our nursing assessment.
Let's go into a little bit about diagnostic testing and lab evaluation of pulmonary function. And these are some of the things that are mentioned in your book. It's important to understand what normal values are and what the abnormal values might indicate, and when you need to intervene and when you need to contact your provider and get some orders. So the first thing is pulse oximetry. And pulse oximetry, many of you might be familiar with this. It usually involves putting a probe on the patient's finger. You can also use other extremities such as an earlobe or toes. In babies we use the feet and the right hand usually to measure pulse ox. Normal value in a healthy adult should be 95 to 100% on room air. Now, last year it seemed like we had a whole bunch of patients where students were reporting values of 72, 86, crazy numbers, and not thinking anything of it. And I would run into the room very frantic and find that patient was breathing normally, put the probe on their finger, 98% on room air, not a problem. And what was happening was people were taking that pulse ox on the same extremity that they were doing with the blood pressure cuff. And when they were constricting the vessels to take the pressure, the oxygenated blood was not going to the extremity. What bothered me a little bit was that they didn't seem to know that 95 to 100 was the normal. And so they would just kind of give me results that said, you know, blood pressure this, pulse ox 72%. And of course it would, you know, send my heart into palpitations. And I would go in there and find a patient who was perfectly normal. So that was a teaching opportunity. Don't let that happen to you. If you see a result that is under 95 and that patient is not, let's say, COPD, where they might live at a slightly lower number because they need that hypoxic drive, you want to get somebody in there, you know, after you've after you troubleshoot some of the normal obvious things, like you have a probe that's not on the right way, or maybe that person has dark nail polish on, you can take that off. You know, maybe your equipment's not functioning well and you get, you know, another post ox. Look at the person's work of breathing, obviously, when you get a number you don't expect. Tell them to take a couple of deep breaths, readjust the probe. But within a couple seconds, if you suspect that there's a problem, get your clinical instructor. Don't wait until post-conference. I mean, that's going to get you in some hot water. So 95 to 100% is normal for pulse oximetry. And, let me get rid of that. Okay, so the next test we're going to talk about is arterial blood gas, or ABGs. You're going to find out a lot more about this when you get to Unit 7, which is Exam 3's content, when you do fluid electrolytes and acid-base balance. And arterial blood gases are a great measure if you suspect a problem with oxygenation, because it measures three things from arterial blood. Arterial blood is the blood that we assume to be oxygenated. It measures the pH, which is how acid or basic. Basic is the opposite of acid. The blood is. And I'll get back to that in a minute. It measures the partial pressure of oxygen in the blood. Okay. And that is normally between 80 and 100 millimeters of mercury. You don't have to take a note now, and you don't have to really memorize it yet. You'll see it again. I promise you it will not be that far off in the future. But when you get numbers that are outside your reference range, you're looking at blood that is low in oxygen. Next, we have the partial pressure of CO2. Sometimes you'll see these things abbreviated as PO2 or PCO2 instead of PA. That's okay. It just depends on how your lab abbreviates that. And this is normally 35 to 45 millimeters of mercury. Anything that's in millimeters of mercury measures pressure, by the way. Blood pressure is millimeters of mercury. Okay, so now we know how gas exchange works because I talked about that. Let's change colors so we can point that out. When your, oh, I changed the colors on everything, huh? Okay, so when your oxygen goes down and your carbon dioxide goes up, obviously there is a problem with gas exchange. You are not getting enough oxygen in and you are not blowing off enough CO2. What will happen in the blood is the blood will become acidotic because the carbon dioxide that is retained in the body, because you're hypoventilating maybe, or because there's a problem with the alveolar capillary membrane, that carbonic acid builds up and your pH will go down. Down is more acid. Okay, so that is basically how respiratory acidosis looks like. Now you don't have to memorize that. Again, you're going to get it. But just know that when people have problems with gas exchange, they end up in respiratory acidosis. Sometimes they compensate for it, sometimes they don't, but that is why we test for an arterial blood gas. Okay? It's more important to know why we test for it and what we're looking at than to know what the normal numbers are at this point. Those numbers become very important to you in just about a month and a half, but that's enough for now. Arterial blood gases. Now, things that nurses need to be aware of with ABGs are that you're getting arterial blood because that's where we assume the oxygen is. Arterial sticks are painful, much more so than venipuncture. You know, people don't like getting IVs, but generally once you pierce the skin, the vein itself doesn't have a lot of nerve endings. Arteries do, and they can go into spasm because there's a muscle wall in the artery. And that can make an arterial stick very painful. The patient should know that. Generally, arterial sticks in your med-surg units are done by respiratory. On the ICUs, when patients have A-lines, they might be drawn off the A-line by a nurse. In NICU, the nurses draw the ABGs all the time. But arterial sticks can be quite painful, and so the patient should be sort of prepared for that. The other nursing consideration you're going to have with that, the sample, you should look at it to make sure that blood looks kind of bright red. If it looks really, really dark, you might be looking at venous blood. A lot of times where they go, you've got veins and arteries in proximity to one another. You feel for a pulse to get the stick. But make sure that the sample is arterial and make sure get all the air out of the syringe. Sorry. If you have any air left over in the syringe, it's going to skew your result. So that's important to know. And the next thing I want you to understand about ABGs are that the puncture site can bleed. You all had anatomy and physiology, and we're going to talk about circulation next. So you know that the veins are kind of like a lazy river, and the arteries are these big rushing rapids. They have muscles that want to pump that blood hard to get it to the tissues, and the veins sort of return it in a more leisurely manner. So a venous puncture site can bleed a little. An arterial puncture site can bleed a lot. So what a nurse is going to do is hold direct pressure on the site for 3 to 5 minutes. Unless you've got a person who bleeds more than most people, they have low platelets or they're on heparin or something like that, then you're going to hold it longer. Sorry. And those are some considerations with your ABGs. Okay, so enough about those. We're going to talk about pulmonary function testing. And pulmonary function testing is an important measure of ventilation, where blood gases talked about gas exchange and the availability of oxygen to the tissues. Pulmonary function testing measures the volume of air that can be inhaled, the volume of air that can be exhaled, and the force with which we can expire our air. And so, you have terms like tidal volume, which speaks to lung capacity, how much air goes in and out. We have things like the FEV, which is the forced expiratory volume. Those are just some terms that you might be familiar with. Spirometry is one type of pulmonary function testing, but just know that when we do pulmonary function testing or PFTs, we're looking at lung capacity, and it's a measure of ventilation, okay? The next test that we can sometimes encounter is TB skin testing. We're all familiar with our PPDs. You had to have one before you came here. And it's that little bubble of protein derivative that they put under the skin. Some people react and not have TB. So the next step is either going to be a quantiferin gold, which is a serum test, and this is particularly useful when you have patients from countries that vaccinate against TB with the BCG vaccine, such as Guatemala or India. In this area, we have populations of people that test positive for TB, and it's because they had that vaccine. Or we can do a chest x-ray, and that'll show changes that are related to TB. The next test we can talk about is sputum culture and sensitivity. We already had a lab on specimen collection, so you sort of understand that we are looking for a bacteria that grows in the lungs, whether it's tuberculosis bacteria or a bacteria that can cause a bacterial pneumonia. And sensitivity, obviously, we already talked about this, I'm sure in lab, indicates what antibiotics might be useful to treat that infection. Capnography is a measure of breathing pattern, and let's bring back that picture that we looked at before. Here it is, all those abnormal breathing patterns and some of the normal ones. That was all measured by capnography, and you see that waveform indicates the inhalation and exhalation, that peak and trough. Okay, so that's capnography. Chest x-ray measures a lot of different things. The one nursing consideration that you're going to remember for chest x-ray is you do want to limit the amount of radiation that patients are exposed to, so it's not a procedure you want to do often or frivolously. You do want to shield sensitive, if they have reproductive organs, they're of reproductive age, you want to shield them with a lead apron. Allergy testing, I only include that because it's in your book. Patients with asthma, a lot of times allergens are triggers, so if we want to know what they're specifically allergic to, the provider can inject tiny amounts of that allergen into the skin, and the skin will react with redness. Okay, and so those are some of the more important diagnostic tests that we use for pulmonary function. Okay, and we're going to have a quick discussion of the nursing diagnosis that's involved with ventilation and gas exchange. And I know that there was a certain amount of uncertainty about which to use and when, so we'll kind of just go through them. When you're making your care plans for clinical, ineffective airway clearance has to do with secretions or obstructions in the airway. So if a person is choking, that applies. If they have secretions that they can't clear, ineffective airway clearance is also important. If they have any swelling of the airway and the airway narrows, ineffective airway clearance again. Ineffective breathing patterns are when we looked at those breathing patterns like hyperventilation and hypoventilation, tachypnea, bradypnea. Those are breathing patterns that do not lead to effective ventilation. Impaired gas exchange is when the person is ventilating adequately, but the gases are on exchange. So they might have excessive carbon dioxide or low oxygen. They're hypoxemic, which is low oxygen in the blood, or hypoxic, which is lack of oxygen in the tissues. So when we see a patient whose ABGs are abnormal, when we see a patient who is satting low and they're ventilating okay, but somehow something's not getting through, that's when we use impaired gas exchange. It happens at the level of the alveolar capillary membrane, and that's sort of important to remember. You might not really understand what that means just yet, but when we look at patients in the hospital who have COPD and their breathing is fine, they're breathing at a normal rate and depth, maybe, unless they're totally labored, but their gases aren't exchanged because the alveoli are hyperinflated and there's not enough gas exchange. That's when we use impaired gas exchange. Okay? Impaired spontaneous ventilation, that's usually a situation where the person does not spontaneously breathe for whatever reason. Either they've been, they've been medicated or there's brain damage, but they can't support life. So the person with impaired spontaneous ventilation needs to be mechanically ventilated. We also have risk for aspiration, and this is when the patient has a risk for aspirating secretions. A lot of times it's due to level of consciousness issues.
Or you have a patient who has like paralysis on one side of the face, they have problems swallowing. Alzheimer's patients have risk for aspiration, and so we put them on what's called aspiration precautions, which is what we'll talk about later. But those are the basic categories of nursing diagnosis. So once you've assessed your patient, you've identified the key problems, it's time to move on to planning an intervention. And you'll notice that a lot of your exam questions, your ATI questions, your practice NCLEX questions deal with either assessment or intervention. Sometimes evaluation, but that's really just reassessment. And it's really what you spend most of your day doing. You assess your patients and then you do something about what you find. So those two sections are going to be really important. We're going to spend some time with them. And our first interventions are targeted at promoting health, preventing illness. So lifestyle modification. So we're going to talk to people about smoking cessation. And it's important to stress to people that it's never too late to quit smoking, that within a few hours they're going to start seeing some benefits. And within 10 to 15 years, their risk of most major disease is equal to or only slightly higher than that of a non-smoker. So that's an important way to promote respiratory health and prevent problems like COPD and lung cancer. Preventing respiratory tract infections is another thing that we can do to help people maintain their respiratory health. And obviously hand washing is important for preventing all respiratory tract infections. Even the common cold is droplet precaution. So disinfecting of surfaces when you have sick people in the home and avoiding people who are sick if you're immunosuppressed. Influenza vaccine and pneumococcal vaccine for adults are important if they're at risk. And in children, we're also going to look at all the other vaccines. There are so many, it's a schedule, and we'll kind of deal with that when you get to peds. But the two that you're going to see in the hospital, most likely we're going to push the influenza vaccine and the pneumococcal vaccine to prevent respiratory illness in people. We also want to stress that people should avoid environmental hazards. So they should wear a respirator mask if they're going to be working around toxic chemicals or if they're going to be dealing with anything that has fine particles, like when you're removing the asbestos panels and stuff. They really need to be protected. Also, environmental hazards goes with allergens. There are some people with asthma, they have reactive airway disease. And so anytime they're around something that irritates them or that they're allergic to, they'll go into sort of bronchospasm. So you want to avoid those things. And also we want to control chronic conditions such as asthma or COPD as much as possible. And there are a lot of things we can do, but those specific things are outside of the scope of what we're talking about today. So, that's some things that we can do to promote health and prevent illness. Okay, so now we're going to talk about how to promote effective breathing. And the number one thing that a nurse can do, if you've got a patient who's having trouble breathing, who gets short of breath frequently, is positioning. And really with positioning, I'm going to point something out. The higher, the better. So at least, 45 degrees, but really higher is better. An 80 or 90 degree angle is fine. But that is going to be one of your major interventions, is positioning. If your patient is laying flat on their back, it's harder for them to, work against gravity to drop that diaphragm and take a big deep breath. So if we have them sitting up, the diaphragm drops down, they have more space to hold the air, and it's generally just easier for them to breathe. Also, when people are supine, especially when they're sleeping, their tongue can block their airway, and so positioning is one of the quickest intervention that you can do. Another thing we can do is breathing exercises. Now, your book doesn't have your fundamentals book, I should say, doesn't have a great big section on this. But let's talk about some things that we can teach people to do. The first thing, when you have a fresh post-op or somebody who's been on bed rest or somebody who just needs to learn to take deeper breaths, is we can use an incentive spirometer. Sorry for my typing there. I'm going to get a picture of that for you. Okay, and this is a little diagram on how to use an incentive spirometer. And basically, you're going to see a lot of these in the hospital. A little handheld device, it's not that fancy. Let me get a pointer on that. As the person inspires or inhales, this little thing up here goes up.
the higher the better. What we instruct patients to do after they had surgery or if they're on bed rest is really 10 times an hour. It doesn't have to be 10 times in a row if they're very tired, if it wears them out. But what we're going to tell them to do is put the mouthpiece in their mouth, take a deep breath in, get it as high as you can, and if you want to set a marker, you usually can. But, just tell the person to breathe as deeply as possible. And then hold it for a few seconds and then let it go slowly. Okay, and if they do that 10 times in an hour, like I said, it doesn't have to be 10 times all at once. While they're awake, they'll keep their airways expanded, and that's going to prevent them from getting conditions like atelectasis, which is, collapse the alveoli. Okay, so that's one type of breathing exercise. I didn't mean to go quite that far. There we go. Another type of breathing exercise we can do is diaphragmatic or abdominal breathing. And we teach people to do this because some people like to breathe with their chest muscles, particularly your emphysema patients, your COPD patients, and it's not the most efficient way to breathe. It takes more work to use those chest muscles than it does to use your abdominal muscles. Now I've put up your reference for this section for diaphragmatic breathing up here because there's a good how-to in your clinical skill book on page 1173. And it's not hard to teach somebody how to do diaphragmatic breathing. You tell them to put their hands on their belly and sort of breathe in through their nose and push their stomach out against their hands. And then they slowly exhale and watch the hands go up and down. And make sure that those hands are rising with each breath and that their hands are on their belly. And that does help reduce the work of breathing and make their breathing more effective. So there's diaphragmatic or abdominal breathing, and then there is pursed lip breathing. And your fundamentals book, again, does not go into detail, but I'll give you a reference. Okay, so if you forgive my lack of APA formatting, I put your textbook reference up here for pursed lip breathing. It's Hinkle and Cheever, your big green and white med-surg book, on page 628. That's where the discussion of pursed lip breathing with COPD is. And pursed lip breathing helps that patient keep that inspired air in as long as possible and sort of force the air out slowly. So what we tell them to do, let me get a picture of that for you. And it'll make sort of more sense. You tell them to breathe in through their nose, okay, slowly, and then purse their lips, almost like you're going to whistle, and blow that out slowly over a count to, say, 4 or 5, whatever that patient can tolerate. But the more they're exhaling that air, the patients with emphysema really need to exhale all their air because their lungs are always slightly inflated anyway. But the pursed lip breathing does tend to help them with their shortness of breath. It makes them feel a lot better. And one more thing that we can do to promote effective ventilation is to make sure that when we administer medications that cause respiratory depression, hold on, let me make that a little bigger, there you go. We need to increase our monitoring and make sure that we're not knocking out that person's drive to breathe, that they're not hypoventilating. Okay, so the next thing that we're going to talk about is mobilizing secretions. So the next set of interventions we're going to talk about are things that are geared towards mobilizing secretions, and that's an important part of maintaining airway patency. If your secretions aren't mobile, they can block your airways, narrow your airways, and they can also sit in the bottoms of your lungs and create a very good environment for infection. And so we need to mobilize secretions. Again, this becomes a problem with your frail elderly who have a hard time coughing up enough, patients who have very thick, tenacious secretions like cystic fibrosis patients or patients with pneumonia, and it's also a problem with your post-ops who maybe don't want to cough because it hurts their incision. So we'll talk about that for a minute. Okay, so the first thing that we're going to do, the most effective thing to clear these secretions and mobilize them and get them out is to encourage coughing. The cough reflex is the most important way to mobilize the secretions. And a patient who can cough effectively will usually keep their own airway patent. So we're going to encourage coughing. Now, how does this work when you have a patient who has an abdominal incision and it hurts to cough? Well, there's something called splinting their incision. Let me show you a picture. And there it is. You see that the patient has a pillow If you don't have an extra pillow or the pillows you have are too soft, you can make one out of a folded blanket or Chuck's pad, whatever you have. And you call it a buddy pillow, and that person hugs that pillow when they have to cough, and that kind of keeps their incision from moving too much. But you definitely want to encourage coughing and deep breathing. Like I said, with the incentive spirometer, it was 10 times per hour. I would, every time you go in there, say, okay, time to cough. The cough reflex, like I said, is really important. We're going to maintain hydration to keep secretions thin. When a person's dehydrated, everything in their body gets drier. And so you want to maintain hydration. If the person can't take in PO fluids, you're going to give them IV fluids. Now, obviously, that all kind of depends on their cardiac status, but one step at a time. Maintain hydration to keep secretions thin. Then you're going to suction if you need to clear the airways, and that was a lab that we had. Suctioning is a little more invasive, and probably its key advantage is that when you hit the pharynx, if you're doing oropharyngeal suctioning, that you'll stimulate that person's cough reflex. Signs that the person needs to be suctioned include like gurgling signs, if they're agitated, especially if they're on a ventilator, if you hear a lot of adventitious wet breath sounds. You can see labored respirations, but the key thing is that you're going to hear something that sounds like there's junk in there, and so you want to help them suction if the person can't cough. A lot of your really frail patients have a hard time coughing, so we end up suctioning them. Be aware, though, that it is sort of a more invasive thing, particularly your nasopharyngeal suctioning, and you can make the nares swell. So use it when you need to. But don't overdo it. Okay, so I put a reference up at the top because now we're going to talk about chest PT and postural drainage. So I'll kind of put that down there. That's from your clinical skills book again, pages 1181 to 1183, in case you're really curious about what postural drainage looks like or chest PT. I will tell you that in your adult med-surg units, you're not likely to see it that often because most patients won't tolerate it. So what postural drainage involves is positioning the patient where their head is lower, and then that affected lobe is up, sort of upright. You're turning them to the side, and then all those secretions get a chance to sort of drain down with gravity and a little bit of help. And what chest PT is, you take your hands and you kind of cup them, or you can vibrate over the areas where there are consolidations, and that sort of gets them moving. You see it mostly with kids who have thick, tenacious secretions, and really a lot of times the kids that need the most chest PT are the ones with cystic fibrosis. So you might not really see that as much on the adult units. Oscillator vests, I've seen oscillators in NICU, and that's usually the whole bed sort of vibrates, and oscillator vests are sometimes used to loosen secretions. But there is a danger with chest PT because you're sort of cupping your hands and not beating them up, but you're striking them in this little percussive motion. If you have somebody who's got severe osteoporosis or they're prone to bleeding, you can bruise them, you can break bones. So it's again not something you're going to see a lot of on the adult med-surg units, but you will see it in peds. And the last thing on this list is to administer expectorants. Now there are a number of medications that affect the respiratory system. An expectorant is a medication that's used to thin secretions. And an example of that might be guaifenesin or Mucinex. Let me put that up for you. There it is. Also goes by the name of Robitussin, so most of you probably have heard of it. And that's a type of medication that's used to thin secretions. There are other medications that are used to prevent coughing or whatever, but that's one of the ones that helps mobilize secretions. And I just want to spend a little time talking about some of the different methods of airway management that you might see. There are some artificial airways that you might see in the healthcare setting. Okay, and here's a picture of an oropharyngeal tube in place, and you can see it kind of holds that airway open, keeps the tongue from obstructing it, and keeps any swelling from closing up that airway. Here's a nasal trumpet or nasopharyngeal airway, and that's inserted if you can't do an oropharyngeal. Again, it keeps the airway open. And we have your ET tube or your endotracheal, and you'll see there's this little, let me get a pointer on that. That's where they inflate this cuff here. And it's a little balloon, and it kind of holds it in place so that it doesn't slip out. There's little markings on here. They come in different sizes for different size patients. But those are some artificial airways. And then we have tracheostomies. And I think most of us are sort of familiar with tracheostomies, but I'll get a picture just in case. There it is. Okay, so that's a tracheostomy, and you're going to get more information on maintaining artificial airways later on. It's really more of an advanced skill. Just know that this is one of the ways that the medical team can keep an airway open. Where I practice, docs are the only ones allowed to really intubate or to put in an airway, except for, I think, nasal trumpets. They go back and forth on whether or not we're allowed to use them. But we do maintain the airway, and especially the tracheostomy. We are responsible for making sure that it's clean and that it's patent and suction as needed. Artificial ventilation is another thing you might see, particularly when you do your ICU rotation. A lot of people might be ventilated. It's not something I really want you to spend a whole lot of time on right now. Just be aware that those are some ways that the medical team does manage the airway. And there are some medications that we use as well. We use steroids when you have somebody who has inflammation of the airway, particularly asthma. We often give them, we can give them inhaled steroids if it's a chronic thing and we want to prevent exacerbations, like Qvar, or there are some combo drugs. But steroids will decrease the inflammation of the airway. Sometimes we give them on a more systemic level. We'll give them prednisone, either orally or prednisolone IV. So that's something that you might see. Other medications, if they're having trouble with secretions because they have a bacterial infection, we'll give them antibiotics for pneumonia or for whatever bacterial infection they have. And then we have bronchodilators. And I think maybe I'll make an addendum to this to help you guys with your templates, because as you get closer to the medication administration lab, we're going to expect you to have your ATI templates completed so that you have or concept map or something along those lines to show that you understand what the medications do before you give them. So a steroid decreases inflammation. An antibiotic obviously fights infection. I do believe you have those on your list. And then you have bronchodilators. And bronchodilators work by opening up all the airways, including the smaller ones, the alveoli. And they are a nice quick fix. They're a rescue medication. But people will sort of go to those rescue meds sometimes and not try to manage their condition a little more appropriately through managing their environment, avoiding environmental triggers, and through, usually there's a good asthma regimen using some inhaled steroids and some rescue medicines. Okay, so that's some ways that we manage the airway. Now, just one last word about airway management. If somebody is choking, I'm going to get you the universal choking sign. And there it is. Okay, you see the man with the hands around his neck. Now, obviously, this is part of BLS. It's really sort of outside the scope of what we can do in the time we have. But if you see this, whether you're in the hospital or in the community or at home, that's the universal choking sign. If the person can cough, you tell them, keep coughing, keep coughing, keep coughing, keep coughing. And that cough hopefully will be enough to clear that airway. If the person can't cough and get that object out of their airway, you can perform the Heimlich maneuver, quick upward abdominal thrusts, different for babies. But again, that's just something that you'll get with BLS. And next we're going to talk about improving gas exchange. Okay, so there are several ways. Most of the time we're going to target the root cause. If it's because there are infiltrates, we're going to address the cause of that, pneumonia, whatever. If there's fluid in the lungs that's increasing the distance that the oxygen has to travel through the alveolar capillary membrane, we're going to do some interventions that target that. But when we're acting quickly, the first thing that we're going to think of is the administration of oxygen. So let me get that up here. Now, we had a lab on this, and I'm not sure what you remember, but let's go over some basic things. Oxygen is flammable. So, you're going to educate your patient. Don't smoke, don't use petroleum products, don't do anything that can cause a spark. And you're going to put a sign by their bed that the oxygen is in use and educate the family not to smoke around it. Another thing to remember is that oxygen is like a medication, and like any medication, it can have side effects and adverse effects. It can be toxic in high doses if you're using it for, especially for prolonged periods. Sorry, lost my train of thought there. There is such a thing as oxygen toxicity. So we only want to administer it when it's appropriate. Okay, another thing that we want to know about with oxygen, there are different delivery devices. We have our nasal cannula, and I'm going to review this even though, like I said, we had our lab on it. That will give you, I've seen 1 to 6, but why bother at 1? 2 to 6 liters per minute of oxygen through this delivery device. Can be irritating to the nares, and the tubing sometimes to the, the ears, the cartilage around the ears. Okay, so we want to watch for that. Sometimes we can put a little bit of foam padding behind the tubing that go behind the ears and with the nares. We don't want to use anything oil soluble, but you can use a water soluble lubricant like KY to sort of help with that. So you want to also humidify your air. Nasal cannulas aren't good for mouth breathers, just to remember that. Okay, and then we have simple face mask. And this can deliver concentrations at about 5 to 8 liters per minute. Now, different books will say different numbers, but they'll all hover around this basic general range of 5 to 8. It'll say 4 to 8, but at 4 you might as well be doing a nasal cannula. And it really, I think it takes about 5 liters. I have read it takes about 5 liters per minute to really get good flow through that mask. So that's your simple face mask. So if you need a little bit higher, let's say you have started with a nasal cannula, your order is to titrate until their pulse ox is 95 or above. So you would go up to a simple face mask. Now if you needed precise concentration, an FiO2, fraction of inspired air, Venturi mask would be your best bet. It has all those little dials on the nozzles to give precise concentrations of air. So somebody who needs 40%, that person needs a Venturi mask. And you will see this with COPDers if their nasal cannulas aren't sufficient. Their providers will usually go to a Venturi mask because it prevents you from over-oxygenating that patient and wiping out their hypoxic drive. And then you have your rebreather masks, or non-rebreather masks, I should say, and partial. Now, the thing that makes a non-rebreather mask is 2 little yellow discs. I know you saw them before. Now, you can deliver close to 100%. I don't know that anything gets you exactly 100% without a tight seal, without being ventilated. But the tighter the seal, the higher your concentration. So you're getting 90 to 100%, and you can get a high flow rate. 15 liters per minute. So when a person needs oxygen fast, now a couple situations where this is appropriate. You have somebody who maybe has carbon monoxide poisoning and they need a lot of oxygen to sort of replace that carbon monoxide in their blood. We'll put them on a non-rebreather mask. We use it a lot in labor and delivery when we're doing intrauterine fetal resuscitation. We want to get mom's O2 concentration up real high because it goes to the baby. But those are a couple uses for non-rebreather, and then there's your partial. And you just remove one of those little gasket things. And that'll give you a high flow with a slightly lesser concentration than the non-rebreather mask. Okay, so here are some nursing considerations, some things that you should know when you're administering oxygen. In addition to the things that we just talked about. It's the nurse's responsibility to maintain patency of the equipment. That means that no kinks in the tubing, all connections have to be secure. If there is a mask, it needs to be sealed to the face. The prongs need to be facing the right way and in the nose. I can't tell you how many times I walk into a room and somebody's wearing their nasal cannula like a headband. You don't want that. Also, you want to make sure every once in a while you feel for the airflow, particularly if you're having trouble maintaining a saturation or the first time you apply it. When you're in home care, you'll notice that people have lots of extension tubing so that they can move around their houses. And so you want to make sure that none of that's getting twisted, that none of the connections are loose, and that nothing is kinked off. And that's going to maintain your oxygen flow. You want to humidify the air. There's little humidifier bottles of sterile water that kind of screw right into an adapter in your wall outlet when you provide oxygen in the hospital. Devices for home care have similar mechanisms for humidification of the air. And you want to provide mouth care frequently because oxygen can be very drying and very irritating, and you can get a lot of dried secretions and stuff. Plus, mouth care is one of the things that helps prevent respiratory infections. So that's another thing you want to do for your patient. You might need to switch from a mask to a nasal cannula for meals if the patient can't eat without the mask, or can't eat with the mask on and can't take the mask off. Maybe switch to a nasal cannula, particularly if the rate is 5 or 6 liters per minute. You want to check skin integrity at all the points where either the tubing or the mask makes contact with the skin. Make sure that you're not too tight. There's straps that go around the head. Make sure that the skin is intact in those areas. If you're using portable oxygen cylinders, and we've all kind of seen these big green canisters, let me get a picture. Okay, there's your oxygen cylinders. You want to make sure that they're always in holders and they're secured properly, because they can actually discharge and become a projectile. It happened at one of the local hospitals. Somebody was injured very badly. It became like a little projectile missile. And make sure that when you're taking somebody out with a portable cylinder, that the cylinder has enough in the tank so that you're not going to run out while you're somewhere and you can't access the oxygen. And the last thing that I'm going to leave you with is that in an emergency, you can start oxygen at 2 liters per minute with a nasal cannula without an order. And then you can increase per order. If it's an emergency, you really should be on the phone with somebody trying to get some help for this patient. So, but in the meantime, you can start oxygen. Usually you'll have to titrate that until you get your oxygen saturation in 95 or 100. So if you're starting to do that as an emergency measure, maybe somebody on the floor can run and get you a simple face mask in case you need to go that next step. So those are some things that have to deal with improving gas exchange with the administration of oxygen. And then under our interventions, I'm just going to talk a little bit about chest tubes only because your book does, but this is a real brief thing. Basically, you're going to get more of this content in senior year. If you see this device at your patient's bedside, make sure that you don't step on any of the tubes. ATI also talks a little bit about what they should look like. There's going to be one chamber that has the drainage and one chamber that's the water seal. And what you should see in that water seal chamber is a gentle sort of tidal up and down. If it's bubbling furiously, it means there's a leak. If you see that, just report it to somebody. But that's mostly if you're in clinical. I don't expect you to manage them. I don't expect you to do anything with them. Just be aware that they're there. Don't step on the tubes. Don't do anything that might dislodge them. Don't disconnect any of the hoses. Don't try to empty them. Just pretty much leave them alone. They need to be lower than the level of the chest, so if you see somebody holding them higher than that level, it's wrong. It needs to be corrected. But that's basically all I really need you to know about chest tubes. So the last piece of the nursing process is evaluation. And this is when we look at the patient again and did the things we do make a difference in how well oxygenated this patient is. Have we maintained patency of the airway? And that should be pretty obvious to you. We want to know if that person's mobilizing secretions, if they're able to cough them up, or are we suctioning frequently enough that we're maintaining that patency. We want to know if they are breathing effectively. Is there ventilation moving enough air in and out of their lungs? Is their breathing unlabored or less labored than it was? If so, we know that our intervention is effective. And really what we want to look at is that the patient has clinical signs of better oxygenation. So there's pulse oximetry would be one sort of criteria there. If their pulse ox was 88 and now it's 97, we succeeded. We're also going to look at ABGs if they're ordered. And we're going to look at the patient's overall status. Are they calmer? Are they pinker? Are they looking a little less frantic? we're going to look at all those signs of oxygenation. And that's really what you're doing when you evaluate the outcomes. Continuing our discussion of oxygenation, we're going to start to talk about how that oxygen, once it's in the blood, is moved into the tissues. And for that, we have two terms that you're going to have to learn. Circulation is the actual transportation system through the blood vessels to get to the tissues. Tissue perfusion is a state of adequate oxygenation of the tissues. The tissues need oxygen to perform important metabolic functions. So those are what those terms mean. We're going to go through a brief A&P review. Again, if you have issues with this, go back to your A&P textbook. You can look a little bit more in pages 968 through, let me see where it ends. I would say 971. And that's going to really tell you more about all the different factors, anatomy and physiology of the heart and cardiac system, cardiovascular system. Okay, so we're going to start, with a little bit of an overview. You have your heart here. Get my pointer on it. Everyone knows the heart. You had anatomy and physiology. That's an easy one to find. The blood comes in. We know it comes in through the right side, goes in through the right atrium, down through the right ventricle. You're not really seeing it here. You need a better picture. Let me get that for you. And I'll kind of overlap it here. Okay, there we are. So it goes in through the vena cava, which is the biggest vein or vessel, venous vessel, into the right atrium. This is deoxygenated blood, by the way. Then it goes through the right atrium into the right ventricle, where it is then pumped out to the lungs. It returns back in through the left atrium with the pulmonary circulation into the left ventricle. Left ventricle pumps it out through the body. Here's the aorta. That's the biggest artery in the body, the major artery. And that's going to pump blood into all the other vessels. Hold on, let me just kind of make that a little bit smaller so that we can see that. Okay, so it goes out into the arteries, and then it branches off into these little arterioles. Finally, it'll get into capillary beds, and then it'll reach the tissues. We have gas exchange at the tissue level, at the cellular level, where the oxygen gets into the tissues by, again, that process of osmosis, or passive diffusion. When the cell has waste products, it'll have carbon dioxide. Let me get that picture up here for you. Okay, because we're done with arteries. So here the blood went in, is going through the artery, and the oxygen and the water, all the nutrients are going into tissue cells. When the tissues are done metabolizing those products, they have waste products. There's excess water, and the carbon dioxide from the cells goes back into the venous circulation via the capillaries. We can shrink that now. Okay, so now it's picked up in the venous capillaries, and it goes into the vanules, which are little venous vessels, and then into the veins, and then into the major, like the inferior and superior vena cava, which are the big vessels, and it goes on and on. Picks up some more oxygenated blood in the pulmonary circulation, back into the left, on and on. Okay? So that's your brief overview. If that is at all confusing to you, or if you feel like, wow, that was a really long time ago and I don't really remember it, pull out your A&P book, or pull out your Wilkinson-Treese book. Even pull out your Hinkle and Cheever MedSurge green and white textbook and take a look. I think even Smith, Duell, and Martin have some, that clinical skills book have some good information on circulation. So if you need a review, go ahead and get yourself one. But we're going to move on a little bit more. So we know that we start in the heart, and the heart requires some electrical activity. I mean, there is brainstem activity as well, that's going to regulate like the rate and rhythm. But the big pacemaker in the heart is this SA node right here, and then it follows a certain pathway. I'm not going to get too in-depth with that. You're going to see it again in senior year, about 4th semester, when you do the cardiac cycle with your senior faculty. Just know that that good circulation requires a good pump with functioning muscle. It requires a good blood supply. Let me show you something here. I don't know if you can see it real well. I'll try and make it as big as possible. But people, a lot of times there's this misperception in the public that when you have a heart attack, it's these big vessels here, the aorta, that gets clogged. It's really not. It's the coronary arteries, or the arteries that feed the heart right here, that get occluded, and that causes tissue death in the heart. So we need a heart that has healthy muscle tissue. We need a healthy functioning electrical system. We need a brainstem that works, because that's going to respond to different signals in the body. When the oxygen gets low, it kicks up a notch and gives you a little tachycardia to try and compensate. When there are drops in pressure, there are different chemicals that are released to increase the blood pressure. So we need a brainstem. We need heart muscle. We need a functioning electrical system. We need patent vessels. If you look at all these vessels here, you'll see, if you occlude one, you're going to stop the roadway. You're going to cause a traffic jam, and that means that cells that are distal to that clot or that traffic jam, that occlusion, aren't going to get perfused adequately. Another thing that you're going to need, let's go back to electrical activity. So your heart pacemaker tries to keep your heart beating in a coordinated rhythm. Coordinated rhythmic contractions give you the best blood flow. It makes sense. If your wiring is faulty and you're not getting good messages to tell the muscles to contract effectively, you're going to get weak pumping action. So you need organized, coordinated electrical activity. This here is a picture of normal sinus rhythm. You don't need to memorize the waveform. It's that PQRST. This has U. I don't usually deal too much with U waves, but the PQRST complex. Plus it should be in a normal rate. That gives you normal sinus rhythm. That's the pattern you like to see. Everything else is kind of all messed up. In fact, some nurses, it's really the two rhythms that they know best: normal sinus rhythm and all messed up. Or normal sinus rhythm and call the doctor. For now, that's all you need to know too. Later on, like I said, so stuff becomes more important. You build on these concepts. They're not things you learn once and forget about. You build a foundation now and you add to it later. Another thing that you're going to need for healthy circulation is red blood cells and the fluid volume to carry those red blood cells. If you are dehydrated or if you are bleeding because there's a hemorrhage situation or shock, again, you don't have a way for that oxygen to get to tissues. Hemoglobin is that red pigment on the red blood cell, and hemoglobin is what oxygenates, or what carries the oxygen to the cells. So if you don't have enough hemoglobin, or you don't have healthy red blood cells, or you don't have enough fluid volume, you're not going to get good tissue perfusion. So those are all the components of healthy circulation and tissue perfusion. Okay, so now that we've identified how the cardiovascular system works generally, we can talk about some individual patient factors that can influence cardiovascular status. So first, let's talk about age. There are some age-related norms. Your vital signs change. New babies with smaller hearts have higher heart rates. Cardiac output, please don't write this down or memorize it. It's, sort of something to stick away for later. Cardiac output depends on two things: stroke volume and heart rate. And so individuals who have a smaller stroke volume, because, and children have smaller hearts, so their stroke volume is smaller, will have a higher heart rate. As you mature into adulthood, by the time you get to adolescence, most of the time your heart rate approximates the healthy adult heart rate, which is 60 to 100. Older adults have a gradual decline in cardiac function. The strength of the muscle sort of weakens, and the vessels become less elastic and thicker and more rigid, which alters the pattern of circulation and perfusion. That is really a highly individual thing, however. There are 75-year-old, 80-year-old people who exercise every day and they're in better health than somebody who is, 120 pounds overweight and 35 years old who doesn't ever exercise. So there are changes related to aging, but it is just one factor among many. Environment. You know what? Yeah, let's talk about environment first, and then I'll go back into something else. I'll write it down so I don't forget it. Your book didn't mention it, but it's still important. We'll just tuck that away. So environment. There are things in the environment that can change the way your heart functions. For one thing, stress. In the short term, an acute stress is going to make your heart beat faster. It's that fight or flight response when your adrenal gland sends out adrenaline and cortisol and those catecholamines. Your sympathetic nervous system starts getting the heart ready to pump more blood to the muscles so that you can run away or you can stay and fight. And so that's a short-term response. Well, over long term, that constant stressing of the cardiac system in the absence of an opportunity to flee or fight just leads to sort of inflammatory changes in the blood vessels. So long-term stress is not good for the cardiovascular system. Unrelieved stress in particular. Heat and cold do influence the blood vessels. Heat tends to vasodilate. That's why you might get warm and flushed, and that pinkish color comes to the skin when you're exposed to heat, when it's hot outside, because you're vasodilating in an attempt to cool the body. Cold will vasoconstrict. That's why people blanch when you give them an ice pack that's on too long. When they get frostbite, there's a lack of blood flow. So heat and cold do influence those things. Altitude. When you live in an atmosphere like the Colorado Rockies for a long period of time where the air is a little bit thinner and less oxygen is available to you in the air that you breathe, your body makes a lot of changes. You're going to get increased vascularity everywhere. You're going to get more production of red blood cells so that there's more oxygen carrying capacity. And the tissue cells are going to be able to take up more oxygen from the blood. They're going to get a little more permeable. And so those are some environmental factors. Now let's go back to this thing that I tucked away to the side. Genetics. Genetics definitely influences your cardiovascular profile. People can have a familial tendency to heart disease, high cholesterol, things that definitely impact cardiovascular function. So when you're doing a history, it's important to assess what their family medical history is. Lifestyle choices, very, very important to the cardiovascular system. Nutrition, obviously, people who eat a lot of heavy, fatty, processed foods aren't doing their blood vessels any favors. They tend to have worse lipid profiles and more inflammatory conditions of the vessels, which can lead to atherosclerosis, and it can lead to high cholesterol, cardiac disease, body weight. People who are obese put bigger stress on their hearts, and they are less able to exercise. And exercise has a protective effect on the cardiovascular system. It's this mild stress that helps the body adapt to changes. And basically, the fitter you are, the more work your heart is able to do with less effort. So we want to encourage exercise when we can. Smoking and tobacco use, horrible for the whole body, but most especially for the lungs and the heart. Causes a lot of vasoconstriction. It can lead to that inflammation that creates vascular disease. You can see more cholesterol deposits. So you'll see more coronary artery disease. So really it acts directly on the heart, but it'll also increase your risk for cerebrovascular accident, CVA, which is also known as a stroke. And it's also going to dramatically increase your risk of peripheral artery disease. That's the vessels in your feet and legs. When you see smokers that come in for FemPop, it's something you'll see on clinical. You don't have to learn it for exam one. But that's a femoral popliteal bypass. Basically, they're grafting stuff so that the blood flow can get to their lower extremities. And that's all from smoking, mostly. And then we look at substance abuse. Certain substances are very cardiotoxic and very toxic to the vessels. Alcohol has a bad effect on the heart. And then we look at, obviously your street drugs, your methamphetamine, cocaine. You can have serious cardiac events from those drugs, and then even marijuana can cause problems over a long period of time. And then even like over-the-counter medications and other medications that are prescribed have effects on the heart. Some are protective, like, you've probably heard of aspirin being prescribed for people, baby aspirin, as a protective thing for the heart. There are other medications like beta blockers that help cardiac function. And then there are medications that have sort of a negative effect on the heart. A lot of your NSAIDs have to be prescribed with caution for elderly people because they do have those negative effects. So those are some things that, I'll put that medications up there so you can make a note. Those are some things that can influence cardiovascular function. So now that we've talked about some factors that will give you risk factors, protective factors, and just variations of normal, let's talk about abnormal conditions. Now, we're not going to get into a very extensive discussion of any of these. I'm really kind of listing them so that when you go to clinical and you're doing your clinical prep, and you see things like this in the past medical history or in the admitting diagnosis, you start to think, how is that going to affect my patient's perfusion? How is that going to affect circulation in the body? How is that going to affect oxygenation of the tissues? You should just start to think like a nurse. When you start to see these diagnoses, they are medical diagnoses. They are not nursing diagnoses. But they'll start you on the path thinking about how you're going to look at this patient from a nursing perspective, because you're going to note that they have possible or potential problems with circulation and perfusion. So here are some conditions. These are some conditions that occur with the heart that pump. Heart failure. There's left and right heart failure. I'm not giving you a diagram or extensive thing. Just know that when your pump doesn't work, the blood doesn't get out of the pump, it doesn't get into the vessels, it doesn't get to the tissues. It in fact backs up usually into the lungs or becomes edema, and that creates a whole set of problems. And so obviously if your pump's not working, that's what happens. Then you have congenital heart disease. This is heart disease that people are born with, and you'll talk more about that when we talk about the newborn at risk and in peds. There are different things that can happen as the heart is forming. The heart forms very early in prenatal life, usually between weeks 3 and 5. And so any insult that happens at that point can sort of influence the path of how the heart develops and can make an abnormal pump. Again, don't memorize that. Just understand if you see somebody who has a history of a congenital heart defect, that you're going to look for alterations in circulation and perfusion. Just start to think like a detective or like a nurse. Cardiomyopathy, that is muscle damage, and that can occur from a lot of things. But what happens, the heart gets bigger or enlarged, and again, it doesn't contract very well as you have muscle damage. It's sort of like a muscle that's been pulled. It's not going to respond to the stimulus to pump. Coronary artery disease. When the heart's not getting enough oxygen itself, there are vessels, like I pointed out in that picture, that supply the heart with its own blood supply, its own oxygen. It takes a lot of oxygen to make that pump work. So if your coronary arteries are blocked, you're going to have places where the tissue isn't adequately perfused. It might in fact die. Angina is a condition where there is decreased blood flow to the heart muscle and it causes extreme pain. It can become more serious, become unstable angina, and lead to myocardial infarction. Myocardial infarction means myocardial is the cardiac muscle. Infarction means death of the tissue. So you have death of cardiac muscle. That's what a heart attack is. Okay, myocardial infarction or an MI. Obviously, if your heart is dying, if cells in it are dying, tissues are dying, it's not going to be an effective way to get blood out to the body. Dysrhythmias, remember we talked in the beginning with the little overview, if you don't have an organized, coordinated rhythm, the pump is going to work chaotically, erratically. It's not going to predictably and reliably supply the tissues with oxygenated blood. And then you have valve issues. Valves keep the blood flowing in the right direction, so when your valves don't work, either they're stenosed, which means they're hard, and narrowed, or they're prolapsed, which means they kind of flop in. When your valves don't work, you can get backflow, and so the heart doesn't move in the right direction, it kind of stays still. So those are some heart conditions that can affect circulation and perfusion. Next, we have conditions that affect the vessels. We have peripheral vascular disease, and that's really vascular disease that affects the arteries that supply the different tissues with blood. So you have arterial insufficiency, and it's easy to tell what arterial insufficiency looks like. It is a pale, cold, hairless extremity, and you're going to see a lot of feet that have arterial insufficiency. The toenails get thick, they're cold. You might not be able to palpate the pulse, you might only be able to get it with a Doppler, and you can see people who have a lot of skin integrity issues with both arterial insufficiency and venous stasis. Now, venous stasis looks a little bit different. That will look like swelling and congestion, and sometimes you'll see a brownish or purplish discoloration in the skin, and that's when the veins don't return the blood back to the heart in an efficient manner. So what you have is blood that pools in the veins. Okay, and this can be dangerous. It can lead to thrombus formation. When blood stands still, it wants to clot. That's what it does. And so when we have people whose venous return is poor, they're at risk for forming a clot. When a clot stays in one place, it's called a thrombus. When a clot moves, it's called an embolism, like an emigrant. It moves out of its spot and into a new one. Usually, a venous thrombus is going to move into the pulmonary vessels and cause a pulmonary embolism. You can also have embolic events in other parts of the body, but generally speaking, that's what we normally see with peripheral vascular disease. You might have a thrombus that forms, and then it becomes an embolus, and that embolus moves to the lungs, and that can be life-threatening. So that's one reason that we want to keep promoting venous return. We have anemias. Anemias do alter tissue perfusion because the blood's getting to the cells. There's just not enough oxygen in it because there's no hemoglobin. Anemias can be caused by deficiency of different nutrients, not just iron, although that's the most common one. And we'll talk about that more in nutrition. I know there's a lot of this video that talks about what we're going to talk about later, but I want you to start thinking about tying together concepts, because everything you're learning now is going to relate to something you need to know later. So none of it is disposable. You know, I can't obviously test on every single thing I'm saying, but it will all become important at some point. None of it is really fluff. Carbon monoxide poisoning does alter tissue perfusion in that it sort of knocks off the oxygen molecule off of the hemoglobin, and it forms a new thing called carboxyhemoglobin. Don't memorize it, don't write it down. But what it does is you'll have a patient who looks nice and rosy pink, maybe even their pulse ox is high, but their tissues are starving because they're getting something that looks like oxygen but isn't, and they can't use it for fuel. And so those are some abnormal conditions that do affect perfusion and circulation. Again, not to be an in-depth discussion, just to acquaint you with things that can affect that patient's status. Now that we're familiar with the cardiovascular system, we're going to talk about assessment, which is the first step of the nursing process again, and this is where you start to feel like real nurses again. Okay, so if you have a patient who's having some kind of emergency or crisis, some acute problem, you have to target your assessment and work really fast. So you might not do all of these things if your patient is having distress. If they're having chest pain, you're going to look at that chest pain and address that first and be ready to respond. Don't waste your time asking them about their smoking history or, how much they weigh. Ask them about the chest pain and, be ready to address it quickly. Okay, but if you have a little more time because your patient's more stable, let's say they just came up to the floor to be admitted from the ER for some other problem, they're going to have gallbladder surgery and you have some time, get a history. Now, it doesn't have to be a separate special cardiac history unless, they're there for that and you want to target it a little bit further. But you're going to ask for family history. A lot of your cardiovascular diseases have a genetic component. Sudden cardiac death tends to be one of those things that you want to assess further if your patient has them. You want to assess past medical history, Certainly if they have any diseases that might influence their cardiovascular status, hypertension, high cholesterol, diabetes, kidney disease, lupus, just to name a few. But you want to get a thorough past medical history and surgical history. Have they ever had heart surgery? If so, what kind? Was it a stent? Was it a valve replacement? Was it to repair a congenital defect? Or did they maybe have a cardiac bypass or pacemaker put in? So those are things that we would want to know. And let me just kind of indent that so you know that's part of the past medical history. We want to know about lifestyle. And we talked about all those lifestyle factors. So do you smoke? How much do you smoke? How long have you smoked? How much exercise do you get? What kind? How much do you weigh? Have you, you want to know about their nutrition, give them a 24-hour diet recall, but as many lifestyle factors as you can to sort of determine what their risk factors are for further disease. And you want to know about medications that they're taking. You want to know if their chronic conditions like hypertension or diabetes are under control with their current medication regime. Are they compliant with their medications? And you want to know about any current complaints. Do they have chest pain? If so, describe the chest pain. Give me some words. Is it crushing? Is it knife-like? Is it dull? Is it a squeezing or a pressure? You want to note if it's, changes with the breathing, because usually that's not a cardiac issue. That can be more of a respiratory issue. So you want to get as much information about chest pain as possible. You want to know about fatigue. Patients with any kind of alteration in circulation or perfusion, including anemia, will complain of fatigue. Obviously, the oxygen's not getting where it needs to go. It's not getting to the brain in adequate amounts. It's not getting to the peripheral tissues. So you want to investigate whether or not they have any fatigue. Shortness of breath is another symptom of heart disease. A cough can be a symptom of congestive heart failure. So you want to get as much information about their current complaints. Investigate any pain that occurs in their lower extremities, particularly if it's one-sided. That can be a deep vein thrombosis. You want to know if they're having any edema, and any like skin ulcers on their lower extremities. Those things can be indicative of cardiac disease, and they can sort of give you some more information to help assess tissue perfusion. Okay, so that's your history. And again, it does not, if you're doing just a general admission or you're out in the community doing, patient education, you don't have to really do a separate cardiac assessment unless they're complaining of cardiac symptoms, and then you want to ask maybe some different questions. Okay, so now that we're done with history, we can talk about inspection. Inspection is something that you sort of start to automatically do as soon as you lay eyes on the patient. You're going to notice their general color and their appearance and their work of breathing. Those, you're going to start to look at everybody that way. How's their color? How are they breathing? Do they look okay? So heart disease can look very often like a grayish or ashen color. Anemia can look like pallor, which is a pale color of the skin. Obviously, any acute crisis is going to give you cyanosis. And so learn to look at the color. Learn to see, look at them too, to see if they look like they're in any distress. If they are tachypnic, or if they're sort of drenched in sweat. Typical heart attack patient has a lot of sweating. Just kind of get a feel for that. If they look anxious or agitated, that's another thing that you might want to investigate a little bit further. You're also going to look at the chest and look for venous patterns on the skin. You'll learn that more in 137. You're also at this point going to look at their extremities, their hands and their feet, because remember that the body is that smart machine, and it's going to prioritize oxygenated blood is going to go to the 3 big places that it needs to. It's going to go to the brain, because nothing works without a brain. It's going to go to the heart to perfuse the heart so it can keep pumping what little it can. And it's going to go to the adrenal glands so that the body has a way to respond via the sympathetic nervous system. So everything else sort of gets bumped to the side, especially the feet and then the hands. Your body can live without fingertips, but it really can't live without a brain. And so we learn to look at the extremities. One test that you're going to do with the extremities to look at perfusion is called capillary refill. And this is a very quick assessment, not hard to do at all, and doesn't hurt.
You just press down on the skin until it blanches and then watch to see how fast it refills. I do it at the fingertips, I do it at the toes. I'm looking at the nail beds for their overall color even before I begin. So even if they're like a little bit pale, I'm noting that, and then I do my capillary refill test. Normal is less than 3 seconds. Let me kind of put that up there. Oops. Most people, it's like an instant refill. Young, healthy people, and your older folks, you're going to see a much more sluggish return, and that tells you that the blood really doesn't get to the extremities very easily. So cap refill is something you do. You're also going to learn to look for edema. Edema is a symptom of heart disease. As the heart becomes less effective, fluid kind of pools where it is. We're also going to start looking at our extremities. Remember that the body prioritizes, and it's going to want to send the best blood, the most oxygen to the heart, the brain, and the adrenal glands. Because really nothing happens without a heart or a brain. The adrenal glands can help the body withstand to the stress of hypoxia and send out those signals to the brain to respond. So that cortisol, that'll keep things going. So we'll see changes in the extremities before we see them in the organs usually. Toes and fingers are the most disposable, and then we have other organs, the intestines, that kind of thing. But the first place we're going to see a problem is in the extremities. So when we're looking at our extremities, we're looking for a lot of things. We're looking to see if there's edema. Edema is that sign of heart disease. We are looking to see, are the extremities pale and cold, which means there is no arterial blood flow to them, or are they congested? With purple or brownish discoloration, or their skin ulcers. Skin ulcers are common with peripheral vascular disease. We're going to look for cellulitis. Cellulitis is usually associated with peripheral vascular disease. Thickened yellow toenails tell us that the oxygen is not getting all the way to the toes. And so those are some things that we look for. And you'll learn more about that all in physical assessment. So those are some things that we inspect for. Palpation, we do use palpation. Mostly what you're going to palpate are pulses. You can also palpate the heart. Sorry, hold on one sec. So you're going to feel your pulses to see what the character of the pulse is. What about its rate, its rhythm, and its depth? Now, if you have a difference between your radial pulse and your pedal pulse, that's significant. If you have so you're going to palpate. Usually when we do a shift assessment, you're at least going to do the radial pulse, the popliteal pulse, and the pedal pulse. Now, when you have arterial insufficiency, remember when you're palpating a pulse, you're palpating that artery that's close to the skin. And so if we don't have we can't palpate a pedal pulse. That tells us that we don't have good arterial flow to that extremity. So we're going to do something with a Doppler. We're going to listen for until we hear that beat. And we're going to note whether it's regular or irregular. And then we're going to take a little Sharpie marker and mark it so the next person can find it as well. And so that's mostly how we use palpation. You're also going to palpate the extremities for temperature. If they are cool, that's a pretty good indication there's not really good blood flow. If they're warm, particularly if they're associated with tenderness or redness, we'd start to suspect a DVT. If it's, especially if it's on one side. And so those are some things that we would palpate for. Okay, so then we get to auscultation, and auscultation is limited to a few things. We listen over the heart, the different valves of the heart. You'll sort of learn that ape to man mnemonic. That's in physical assessment. You'll get there, don't worry, so we're not going to beat that to death. But you're listening for murmurs, which indicate sort of a backflow of the blood. That's why you listen over all the valves. The valves are supposed to keep the blood flowing in, the right direction. And so when that system sort of fails, you'll hear a murmur, which is, we'll kind of talk about what that is in 137. It's an interesting sound that, you kind of have to hear it to understand fully what it's going to sound like. So we'll play some audio files for you then. You can also auscultate over the arteries, like the carotid artery, the abdominal artery, for what's called a bruit. A bruit is a sign of turbulent blood flow, and it means that the artery is not pumping forcefully enough, that some of that blood sort of goes backwards. And so you'll hear it's sort of like a whooshing sound. And so that is most of our assessment. We'll go on to diagnostic testing.
So the first thing I want to point out, and your book makes a good point of it on page 977, is that a lot of our tests that we use for the respiratory system, like pulse oximetry or ABGs, are just as significant for the cardiovascular system. The heart and the lungs work together. They're sort of a team. That's why I put this all in one big, long, heavy video, even though it was split into 2 chapters. So oxygenation is oxygenation. You want to look at the arterial blood gases to see how well oxygenated that person is. Now we have some other blood tests that you get from venous samples, and one of them, let's talk about a CBC, because that's going to give you your hemoglobin and hematocrit. For our purposes, we're really worried mostly about the hemoglobin because that's what carries the oxygen. So low hemoglobin tells us that we don't have such great oxygen carrying capacity. We look at things like blood lipids. We look for cholesterol, which is, there are different factors in the cholesterol. We can look for cardiac enzymes. When the heart muscle is damaged, it releases cardiac enzymes, CK markers. We can look at CRP, C-reactive protein, which is a marker for inflammation. And there is a cardiac-specific CRP, which tells you if there's inflammation of the heart. So those are some of the blood testing that we might do. You could also do glucose testing because diabetes does impact the vascular system. But that would be sort of where you would start. So that's that. And next we can look at some other diagnostic measures that sort of measure the heart a little more directly. We have electrocardiogram or ECG. You might also see that as EKG, and this measures the electrical activity in the heart. It can be either 3-lead or 12-lead, but it will measure those impulses, that PQRST complex that we talked about earlier in this whole episode. So that's something that you might see. An echocardiogram is an ultrasound of the heart. Sometimes they go right over the chest, sometimes they go through the esophagus in what's called a transesophageal echocardiogram, and I'm only going to include that not because it's a test item, but because it's very common to see that on 2A. So those of you who are on 2A with me, or whoever your clinical instructor is that's on 2A, you might hear that your patient went for a TEE, which is a transesophageal echocardiogram, which can measure a lot of important things and give you good data. Another test that you might see are Doppler studies, particularly if you suspect a deep vein thrombosis in a leg. They can order Doppler studies to see what the blood flow is like. If they're worried about perfusion to an organ, they can also do that. So those are some examples of some of the testing that you might see. We didn't talk about a stress test. That's usually you put somebody on a treadmill, have them exercise to their peak, to the extent that they can, and you measure their EKG at the same time. So those are some measures of cardiovascular status that you might see in the hospital. So the next phase in our nursing process is diagnosis. This is where we identify the problem. You don't always get too many questions on nursing diagnosis, but it becomes part of your reasoning and it becomes fairly automatic over time. So one of our nursing diagnoses that's NAMDA approved is decreased cardiac output. Now, of course, you're going to have a related to factor. If the pump failure is the main problem, then it's related to altered contractility. If it's because you've put your patient's in hypovolemic shock and there's no fluid volume to carry the oxygen and nutrients to the cells, then it can be related to decreased fluid volume. And then, of course, your as evidenced by is going to be whatever your assessment findings were. So that is one possible nursing diagnosis. You can have risk for ineffective, tissue perfusion, and that can be related to your patient's cardiac output. A risk for diagnosis is going to tell you that the patient has not manifested the problem yet, but we know that there are risk factors and we would like to address them before there is an actual problem, so that's why we're putting it in our care plan. So you can have risk for ineffective tissue cardiac, which means that person's at risk for a heart attack. You could have it as cerebrovascular if they're at risk for stroke. You can have it as at risk for renal perfusion, whichever tissue that you're targeting. Now, if you have actual ineffective tissue perfusion, you can specify, ineffective tissue perfusion. Usually we can put, say, peripheral in there. And that will tell you that on your assessment you found a limb that was had evidence of poor perfusion. Either there was arterial insufficiency or there was poor venous return. And so you've identified that as a problem that you're going to target for intervention. And so those are some of the things that you might see. Ineffective tissue perfusion to a system or organ, like that, let's say there was injury. And we've noticed that there is poor renal output, your kidneys aren't putting out, and we can say renal. Related to, we could say bleeding. Patient has no blood volume, as evidenced by oliguria. Okay, so that could be like a nursing diagnosis that relates to ineffective tissue perfusion. And just because we kind of address the kidneys, I'm going to tell you, urinary output is a really good indicator of cardiac output. If the heart isn't pumping blood to the kidneys, they're not going to do their job, and you're going to retain urine. So no BP, no PP, no cardiac output, no renal output, and that's kind of a good way to remember that. And that can be from a number of problems. So those are some nursing diagnoses you might use. Now, obviously, cardiovascular problems or problems with tissue perfusion can cause other nursing diagnoses to become important, like activity intolerance or pain secondary to insult, hypoxic insult to heart tissue. You can have anxiety related to shortness of breath and those kind of things. But those would be sort of secondary nursing diagnoses. And so those are some diagnoses that we can use. Okay, so now we're on the planning and intervention phase, and there's a number of things that you as a nurse can do to help people have better cardiovascular status. And we always try to put an emphasis on health promotion and risk reduction. And so one of the things that you're going to do is educate the patient so that they can control the risk factors that are related to lifestyle, like smoking, like nutrition, like their body weight, all of those things. Controlling chronic conditions. All these things are amenable to education. A lot of things that really impact the patient's health are in their hands, and the best that we can do with them is to educate and document that we did that education. Okay? And when we get to like the secondary interventions, things that we actually have to do to patients, we like to promote venous return and arterial circulation. So let's start with venous return. You can elevate the patient's legs. Oh boy. Avoid crossing the legs. That compresses the vessels. Elevation will help the blood return to the heart. Crossing the legs kind of creates an obstruction or a kink in the works, and the blood doesn't always get back. If a recliner chair is available, the patient can sit in one that elevates the legs. We want to use compressive devices, and by this I'm talking about your TED stockings, which are, kind of like a support hose. What you'll see more of in the hospital is a sequential compression device. These are little boots that hook up to a pump. That pumps it like sort of inflates a cuff, sort of massages the blood back towards the body, and this is an important way to prevent deep vein thrombosis. Every surgical patient, every patient on bed rest, people who are in bed more than they're out of it really should be on SCDs, whether they're young and healthy or whether they're older and, a little more debilitated. If they're not moving, they should have SCDs on. We're going to encourage any kind of exercise like range of motion, just to get that blood moving. The more movement, the more, the valves will sort of get that blood back to the heart. And one of the big things, particularly after surgery, bed rest, we're going to find in physical activity and mobility, is not a benign intervention. It sounds so comfy to lay in bed. It is horrible for your body. So the first thing we're going to do with these surgical patients is to encourage ambulation. as early as you can. Some patients post-op, we're getting them out of bed 8 hours after surgery. Even if we're just dangling them and getting them to walk 2 steps to a chair. Ambulation is the best way to prevent venous stasis problems, including a deep vein thrombosis. And so, you really have to push this with your patients. They might be tired, they might have pain issues, they need to walk. And that's going to keep them from getting all kinds of complications, including the respiratory complications like atelectasis, including bowel complications like ileus. And we'll talk more about these as we go. But ambulation is really, really key to promoting good tissue perfusion. Okay, so now let's talk about promoting arterial sufficiency. And really, for this, a lot of it is lifestyle education, avoiding smoking, getting some exercise, doing good foot care. Let's talk for a minute about foot care, because we're going to see signs and symptoms in the feet first. Foot care includes inspecting the feet daily, wearing well-fitting shoes and socks. Warm, clean, dry socks. White is probably better because A, you can bleach them, and B, you can see any kind of drainage that comes in from an ulcer. You're also going to make sure that you use lotion. You're washing your feet daily while you're inspecting them. And see a podiatrist if you have peripheral arterial problems. A lot of our medication, or a lot of our interventions are going to center too on collaborative interventions like administering medications that control disease like diabetes and we'll put hypertension for now, and medications that increase cardiac output so that those arteries will pump all the way to the tissues that need it. So we're going to look at medications like your beta blockers, like your inotropics. You'll learn more about these as we go, and I'll probably start pushing you guys to do your med templates a little bit sooner. But we're going to do like vasodilators, things that are going to promote circulation. Promoting blood sugar is a big thing. So glucose control, helping with glucose control. And this is always a team effort. A lot of it is done by the patient, so a lot of it comes down to exercise, but some of it will help, the nurse can help choose foods that are appropriate, can help encourage exercise, and certainly you're going to help that person measure their blood glucose, and hopefully you'll cover it, and that'll all require orders from a provider. Now another thing that we're going to do is prevent clot formation, because clot formation causes all kinds of problems. It can cause your coronary syndrome. It can cause pulmonary embolism. So a thrombus, just so we're clear, is a clot that stays where it is. I think I might have said this before. When it moves, it emigrates, it becomes an embolus. Where do most emboli go? To the lungs. Some go to the coronary arteries, some go to the brain. But that's basically something we don't want to have happen. Now, blood clotting is essential. Every time you cut yourself, you need your blood to clot. But we don't want blood to clot within the vascular system because that's just bad. So for this, all those interventions we talked about with our sequentials and our ambulation and that kind of thing will also apply. And we're also maybe going to administer anticoagulants as ordered for post-ops, for people who are at risk for clotting. If they have, Lovenox or heparin, that's something that we're going to look at. So there are some oral anticoagulants like Coumadin. Again, we'll start talking about these as we move along. Turning patients, just turning patients, helps that blood move, helps the venous return, changing their position. So So if you're too stationary, I mean, that's a lot of people get blood clots when they fly a lot because they're stuck in a plane seat for a long period of time, and blood that stays still wants to clot. That's just what it does. And so if you've got maybe somebody who's got a pressure point on a vessel, and then their blood doesn't move and they don't change position, they're more likely to clot. Okay, we're going to watch our IV lines and not try to get any thrombi in there. Promote adequate hydration. This is important. Remember, we talked about fluid volume as being one of the components of the cardiovascular system. It sort of makes the roadways go a little bit faster. When blood is concentrated, it's sort of more sluggish. And again, blood that stays still wants to clot. That's just its nature. So promoting adequate hydration, whether oral or IV, oral is always better. You want to get this person drinking fluids if they can tolerate them, because concentrated blood is going to clot more readily. Okay, and lastly, we're going to talk a little bit about what to do if you have an emergency, a cardiac emergency. When there's a cardiac arrest and you are in hospital, every hospital has a procedure, a number that you call and say, I need a code. And it's usually code blue everywhere I've ever worked, but it could be, you have to kind of go by agency policy. Usually it is a code blue. And that's going to get you help. In the meantime, you can start CPR if you're trained in BLS, which all of you should be. Certainly you want to get people to bring that code card and the defibrillator pads, because defibrillation is going to be a key thing. And really talking about how to do CPR is outside the scope of this unit, but keep up with your BLS course, and that's going to help. And if you're not in the hospital, call 911, obviously, if you have a cardiac emergency. The sooner you get help for somebody who's having a cardiac emergency, the better, because early defibrillation is really going to be the key. And then you, of course, initiate CPR until help arrives. Okay, so when we talk about evaluation of outcomes, it's pretty self-explanatory. We're going to go back to our nursing diagnosis and our goals and our planning and see if our interventions were effective. And so if we were looking at risk reduction, did the patient remain free of signs and symptoms of whatever they were at risk for? So we'll put DVT, or ineffective cardiac tissue perfusion, whatever it was that we were targeting. Did they remain free of those things? So those are their risk. How about if they were knowledge deficient about their risk for heart disease, and we did some education on that patient? Did the patient verbalize understanding? Did they change their behavior accordingly? I mean, if we talked to them about diet and they ordered a salad instead of a cheesesteak, that's progress. It's proof that they sort of met their goals. And then we're going to look at some of the actual diagnoses. If they had ineffective tissue perfusion, peripheral tissue perfusion, is the patient showing signs of improved circulation? Are they free of chest pain? Are they, breathing easily, free of shortness of breath? So those are some of the things that we would look at. If we used our secondary diagnoses like anxiety or activity intolerance, are they tolerating activity? Free of anxiety. So whatever it was that we diagnosed, whatever it was that we planned, we're going to see if our plans worked. And so we reassess our patient. And that really is the end of this really, really, really big unit. After this, things get a little bit easier. I hope you were able to take some breaks in between and pause and try and assimilate this material. We'll work with it in class. Bring your muddy points and tell me what it is that you maybe had a little trouble with, and we'll work through it. But thank you for sticking with it.